Gastrointestinal and hepatic manifestations of systemic diseases. Frederick Weber *37. Numerous systemic diseases have GI and hepatic manifestations, but only common diseases and those with recent developments will be discussed in this chapter. Involvement can occur via changes in GI/hepatic structure, function, or both, and may relate directly to the systemic disorder or indirectly via effects of therapy. It should be noted that rarer conditions such as PSS, scleroderma, and amyloidosis are likely to be studied in tertiary care centers, which may be biased toward the sicker patient. The reader is also referred to other chapters where the GI and hepatic manifestations of specific systemic disorders are discussed in greater detail. Collagen vascular and inflammatory diseases, Table 37.1. Rheumatoid arthritis RA has a prevalence of 0.5% to 1% in North America and Europe. 1,2 GI symptoms are common and are largely due to medications, particularly NSAIDs. Oropharyngeal symptoms occur as a result of xerostomia and involvement of the temporomandibular joint, cervical spine, and larynx, particularly the cricoretinoid joint. 3,4 Atlantoaxial subluxation may result in dysphagia associated with other signs of spinal cord compression. Endoscopy is a high-risk procedure in these patients. Esophageal dysmotility, characterized by low peristaltic pressure in the lower two-thirds of the esophagus and reduced lower esophageal sphincter, lay, pressure, is associated with heartburn, dysphagia, and esophagitis. Associated rheumatoid vasculitis, Sjogren syndrome, SS, or amyloidosis, all discussed. Rajiv Jain, Dwayne L. Tila, and Ellen Ebert contributed to earlier versions of this chapter. Table 37.1 Gastrointestinal manifestations of collagen vascular and inflammatory diseases. 37 Disease abnormality/disorder. Clinical manifestations RA temporomandibular arthritis, impaired mastication, esophageal dysmotility, dysphagia, heartburn, vasculitis, intestinal ulceration and infarction, perforation, bleeding, amyloidosis, pseudo-obstruction, malabsorption, PLGE, intestinal ulceration and infarction, gastric outlet obstruction, Felty syndrome, hepatosplenomegaly, abnormal liver biochemical tests, adult onset still disease, liver disease, hepatosplenomegaly, abnormal liver chemistry tests, hyperferritinemia, systemic sclerosis, esophageal dysmotility, dysphagia, heartburn, Barrett esophagus, esophageal candidiasis, gastroparesis, nausea, dyspepsia, intestinal dysmotility, constipation, pseudo-obstruction, malabsorption, PLGE, SIBO, pneumatosis, cystoids intestinalis, true diverticula, pancreatic disease, pancreatic exocrine dysfunction, calcific pancreatitis, anal dysfunction, incontinence, rectal prolapse, GI bleeding, gastric entral vascular ectasia, telangiectasias, SLE, mesenteric vasculitis, bowel ischemia, ulceration, esophageal dysmotility, dysphagia, heartburn, pancreatic disease, pancreatitis, serositis, ascites, peritonitis, liver disease, abnormal liver chemistry tests, hepatitis, polymyositis/dermatomyositis, skeletal muscle dysfunction, impaired glutition, tongue weakness, aspiration, dysphagia, dysmotility, heartburn, dysphagia, gastroparesis, pseudo-obstruction, pneumatosis, cystoids intestinalis, Sjogren syndrome, xerostomia, angular cheilitis, tooth decay, oral candidiasis, hoarseness, esophageal dysmotility, dysphagia, pancreatic disease, pancreatitis, liver disease, abnormal liver biochemistry, chemistry tests, PBC, AIH, HCV infection, mixed connective tissue disease, esophageal dysmotility, scleroderma, 2 changes, vasculitis, heartburn, dysphagia, malabsorption, PLGE, pseudo-obstruction, pneumatosis, cystoids intestinalis, bowel ischemia, ulceration, perforation, polyarteritis nodosa, vasculitis, bowel ischemia, ulceration, perforation, arterial aneurysms, acalculous cholecystitis, sclerosing cholangitis, pancreatic diseases, association with HBV infection, Hainock-Schön line, purpura, vasculitis, abdominal pain, GI bleeding, intussusception, eosinophilic granulomatosis with polyangiitis, eosinophilic phase, eosinophilic gastroenteritis, eosinophilic ascites, vasculitic phase, abdominal pain, bleeding, intestinal ulceration. Perforation granulomatosis with polyangiitis, oral disease, oral ulcers, gingival hyperplasia, strawberry gums, lingual infarction, vasculitis, esophageal and gastric ulcers, bowel ischemia with ulceration and perforation, pancreatitis, gangrenous cholecystitis, Behçet disease, vasculitis, oral ulcers, ileocecal ulcers, and perforation, amyloidosis, large vessel disease, portal or hepatic vein thrombosis, aneurysms, spondyloarthropathies, associated intestinal inflammation, acute disease. Resembles bacterial enteritis, chronic disease, resembles Crohn disease, familial Mediterranean fever, serositis/amyloidosis, peritonitis. Symptoms resembling an acute abdomen, Kogan syndrome, Crohn disease, mesenteric vasculitis, rare, bloody diarrhea, abdominal pain, fistulas, fissures, hemorrhage, ulceration, intestinal infarction, intussusception, Marfan/Ehlers-Danlos syndrome/joint hypermobility syndrome, defective collagen, megaesophagus, hypomotility, diverticula, megacolon, malabsorption. Perforation, arterial rupture, IgG4 related disease, infiltration/fibrosis, autoimmune pancreatitis, sclerosing cholangitis, hepatitis, retroperitoneal fibrosis, inflammatory pseudotumor, aortitis, sclerosing mesenteritis, enteritis, colitis, pouchitis, AIH, autoimmune hepatitis, PLGE, protein-losing gastroenteropathy. 534 Part 4 Topics involving multiple organs later, may also cause esophageal symptoms and dysmotility, and vasculitis may induce esophageal strictures from ischemia. PUD may occur in relation to anti-inflammatory medications. Chronic superficial and chronic atrophic gastritis is seen in 30% and 65%, respectively, of biopsy specimens from patients with RA. About 1/3 of patients with RA have hypochlorhydria or achlorhydria, predisposing them to small bowel bacterial overgrowth, SBBO. Hypergastrinemia may be associated with achlorhydria, antiparietal cell antibodies, vitamin B12 deficiency, or pernicious anemia. 3,5,6 RA is sometimes associated with ulcerative colitis, and rheumatoid vasculitis may mimic IBD. 7-9 Unlike RA, IBD-related peripheral arthropathy is usually rheumatoid factor, RF, negative, non-deforming, and non-erosive. RA may rarely be associated with pneumatoses cystoides intestinalis, Fig. 37.1. Rheumatoid vasculitis, an inflammatory condition of the small and medium-sized vessels, affects about 1% to 5% of patients with RA, typically those with severe disease and high RF titers. 10,11 About 10% to 38% of these cases have intestinal involvement, often associated with manifestations in the skin, digital gangrene, cutaneous ulcers, and peripheral nervous system, neuropathy, mononeuritis multiplex. Involvement of small vessels in the gut results in ischemia with ulcers, pain, and hemorrhage. Involvement of large vessels may lead to bowel infarction, stricture formation, bowel perforation, or hemiperitoneum. Therapy may include glucocorticoids and/or cyclophosphamide based on small uncontrolled studies. Notably, an increased rate of lower GI tract perforations has also been found in RA patients managed with tofacitinib or tocilizumab but not TNF inhibitors. Hepatic involvement. Clinical evidence of liver disease is generally absent in RA. Serum aminotransferase and bilirubin levels are usually normal, whereas serum alkaline phosphatase, both liver and bone isoenzymes, may be elevated. 12-14 Liver histology is nonspecific, including portal tract inflammation, congestion, fatty change, sinusoidal dilatation, amyloid, periportal fibrosis, and nodular regenerative hyperplasia. 15 RA is rarely associated with PBC, autoimmune cholangiopathy, and autoimmune hepatitis, AIH. 14,16,17 Felty syndrome, a triad of neutropenia, splenomegaly, and severe RA, may be associated with hepatomegaly and abnormal liver chemistry tests. Portal hypertension may occur due to distorted liver microarchitecture, from nodular regenerative hyperplasia, or increased splenic blood flow from splenomegaly. In the latter case, splenectomy may decompress varices. 18 Because HCV infection and RA are common diseases, they may be found concurrently in the same patient. Patients with HCV often have arthralgias, Sika syndrome, and myalgias and express RF and ANAS.19. A subset of HCV patients develops mixed cryoglobulinemia with arthritis that may be confused with RA. It is usually a non-destructive mono or oligoarthritis affecting large and medium-sized joints. Anticyclic citrulliнаted peptide antibodies are rarely found in such subjects and are thus reliable markers of RA when present. 20 Treatment of RA patients with TNF-alpha antagonists may not reactivate underlying HCV, although long-term effects are unknown. 21 A review of 216 HCV-infected patients exposed to one or more TNF antagonists over 260 cumulative patient years revealed only 3 cases of drug withdrawal due to hepatic issues. 22 In contrast, anti-TNF-alpha therapy and other immunosuppressive agents may exacerbate HBV, and antiviral therapy may be needed in selected HBV-infected individuals. 23 About 2% of patients who are either HB surface antigen positive or HB core antibody positive receiving conventional immunosuppressive therapy for RA will experience HBV reactivation. 24 Drug-induced side effects. Salicylate-induced hepatotoxicity is often asymptomatic, most commonly occurring with high doses of the drugs. 3,25 Elevated serum malt levels correlate with salicylate levels, are dose-related, and return to normal within a few days after aspirin is discontinued or the dose reduced. Biopsies show mononuclear cell infiltrates in portal triads with little hepatocellular necrosis, although rare cases of severe hepatic necrosis occur. NSAIDs may rarely be hepatotoxic, especially when used with other potentially hepatotoxic medications. 26 Ibuprofen has been associated with a hepatocellular or cholestatic picture, including the vanishing bile duct syndrome. Sulfasalazine may cause a delayed hypersensitivity reaction, occasionally leading to liver failure. 27 Patients may develop a rash, lymphadenopathy, nausea, vomiting, eosinophilia, and either a hepatocellular or mixed liver pattern generally within 6 weeks of starting the medication. Methotrexate has been associated with hepatic fibrosis and cirrhosis, particularly in patients with psoriatic rather than rheumatoid arthritis. Up to 25% of RA patients may have modest serum aminotransferase elevations, but it is not clear these correlate with fibrosis or cirrhosis. Although cofactors such as diabetes, obesity, alcohol use, and NAFLD may play a role, chronic hepatitis B and C do not. 28 Azathioprine and mercaptopurine have been associated with transient asymptomatic rises in serum aminotransferases, cholestatic injury, and chronic hepatic injury marked by peliosis hepatitis, nodular regenerative hyperplasia, and sinusoidal obstruction syndrome, usually occurring in the first 5 years of therapy. There also appears to be an increased risk for lymphoma and possibly hepatocellular carcinoma. Hepatosplenic T-cell lymphoma has been reported rarely in mostly young males on combination azathioprine and TNF inhibitor therapy and presents with fever, fatigue, pancytopenia, and hepatosplenomegaly. The diagnosis is established by bone marrow or liver biopsy and prognosis is poor. Leflunomide can cause diarrhea and hepatotoxicity, usually within the first 6 months of treatment, and is associated with abnormal liver stiffness, especially in the presence of methotrexate. 29 Adult onset still disease. Adult onset still disease, the adult form of juvenile RA, is an inflammatory disorder presenting with spiking fevers, pharyngitis, evanescent maculopapular rash, arthralgias/arthritis, and Fig 37.1 CT showing pneumatosis cystoides intestinalis, arrows, in a patient with RA, from Ebert E.C., Hags-Peel K.D. Gastrointestinal and hepatic manifestations of rheumatoid arthritis. Dig Dis Sci 2011, 56:295-302, with permission from Springer. Chapter 37 Gastrointestinal and Hepatic Manifestations of Systemic Diseases 535-37 Neutrophilic leukocytosis. 30-32 Abdominal pain is usually mild and transient but may be severe. Occasionally, small bowel distension and air fluid levels are found. Hepatosplenomegaly and lymphadenopathy are common. Ferritin is often extremely elevated. 33, C-reactive protein and ESR are high, whereas ANA and RF are negative or low titer. 34 Abnormal liver chemistry tests occur in 50% to 75% of patients and are usually mild and transient, correlating with disease activity. Severe hepatitis and even fulminant hepatic failure occasionally occur, leading to death or liver transplantation. Liver histology may be normal, show portal mononuclear cell infiltration, or interface hepatitis with lymphoplasmacytic inflammation similar to AIH. Portal vein thrombosis has been described. 35 Treatment may include NSAID, glucocorticoids, methotrexate, cyclosporin, and anakinra, with rare hepatotoxicity being reported with anakinra. 36 Systemic sclerosis symptoms related to anywhere in the GI tract may be found in over 90% of patients with PSS, but esophageal symptoms may predominate. 37 Patients most commonly complain of anorexia, reflux, dysphagia, early satiety, nausea, distension, diarrhea, constipation, fecal incontinence, and a decline in social and emotional well-being. 37-38 Malnutrition is common, occasionally requiring parenteral nutrition. 38 Among its causes are anorexia, delayed gastric emptying, malabsorption, SBBO, and slow small bowel transit. The long-standing theory is that a neuropathic process occurs first, followed by a myopathic process as the muscles atrophy and fibrosis develops. Only in the first stage would prokinetic agents be effective. 39,40 Serum antimuscarinic 3-acetylcholine autoantibodies that may block neurotransmission may then lead to secondary tissue/muscle atrophy. 41 Myositis-related antibodies may also be found in a subset of PSS patients. 42 Esophageal involvement. Esophageal symptoms in PSS include heartburn, regurgitation, and dysphagia. Reflux is due to 1. Low/absent esophageal peristalsis, 2. Reduced lay pressure, 3. Hiatal hernia, from a foreshortened esophagus, 4. Gastroparesis, 5. Autonomic nerve dysfunction, 6. Sicca syndrome with loss of salivary bicarbonate, and 7. Increased abdominal pressure from coughing and straining. 43 Patients with PSS develop Barrett esophagus, with an increased risk of esophageal adenocarcinoma, although the most common malignancy is probably lung cancer. 44,45 Delayed esophageal transit, treatment with immunosuppressive drugs, and gastric acid suppression predispose to candidal esophagitis. Pill esophagitis may occur secondary to increased mucosal contact. PSS mainly affects the smooth muscle in the lower two-thirds of the esophagus. The upper esophagus, composed mainly of striated muscle, is usually spared and less affected by proximal reflux. 46 The dysmotility documented by esophageal manometry helps diagnose PSS. It classically shows low amplitude contractions or a peristalsis in the lower two-thirds of the esophagus, and low or absent lay pressure, Fig. 37.2. These findings, however, are not universally seen nor specific to PSS and can be seen in other diseases, such as amyloidosis, diabetes, chronic alcoholism, esophageal candidiasis, severe reflux, hypothyroidism, and other connective tissue diseases. 43 In 200 patients with scleroderma, 117 limited, 83 diffuse, who underwent high-resolution manometry and had their findings classified according to the Chicago classification, the most common findings were absent contractility, 56%, normal motility, 26%, and ineffective motility, 10%, irrespective of whether they had limited or diffuse disease. Classic scleroderma esophagus was observed in only 33%. Severe dysmotility was associated with disease duration, interstitial lung disease, and GI symptom scores. 47 Moreover, in 111 patients with systemic sclerosis, 89 women, who underwent high-resolution manometry that involved multiple rapid swallows, peristaltic amplification during multiple rapid swallows was much less frequent, 18%, than in young healthy controls, 100%. Abnormal peristaltic reserve was the most common manometric abnormality in patients with systemic sclerosis. 48 Impedance studies show incomplete bolus clearance. 46,49,50 Like achalasia, the esophagus may be dilated on imaging studies, but in PSS there is no mechanical obstruction and, therefore, no air fluid levels are seen unless a stricture is present. Endoscopy often shows abnormalities even without symptoms. 51 Endoluminal ultrasonography shows hyperechoic abnormalities in the muscularis propria thought to represent fibrosis. 43 Reflux May A. B. Springer Science and Business Media, 2009. Fig 2.23, p. 38, with permission. The esophagus. From Conklin J., Pimentel M., Soffer E. Color Atlas of High-Resolution Manometry. New York, returns toward the darker blue seen in the empty esophagus, indicating that the bolus was not cleared from coinciding with the opening of the UES. Without a peristaltic pressure wave, the lighter blue color only slowly generates a bolus pressure, seen as a simultaneous shift to the lighter blue or higher pressure, arrowhead. At the gastroesophageal junction, there is a small hiatal hernia and the less relaxes appropriately. The WS peristalsis in the striated muscle esophagus are normal. There is a peristalsis of the smooth muscle esophagus. Determine whether the lower esophageal sphincter, LA, relaxes. B. In the HRM color contour, the UES and ERAT's normal relaxation of the upper esophageal sphincter, UES, but no esophageal peristalsis. It is difficult to Fig 37.2a, high-resolution manometry, HRM, in line mode from a patient with PSS. A wet swallow, WS, Gen 536. Part 4 Topics involving multiple organs contribute to pulmonary disease by aspiration of gastric contents and/or vagal stimulation from gastric contents in the esophagus. Conversely, pulmonary disease may contribute to reflux by greater negative intrathoracic pressure required for ventilation and by the effect of bronchodilators lowering lay pressure. Esophageal reflux is associated with interstitial lung disease in PSS 43,52,53. These manifestations may evolve together. Although a cause-effect relationship has not been definitively proved, centrilobular fibrosis with a bronchocentric distribution is found in 21% of PSS patients with intraluminal basophilic content consistent with peptic necrosis, suggesting a pulmonary reaction to aspiration of gastric contents. 54 Pulmonary disease is a major cause of death in PSS and responds poorly to treatment. Aspiration precautions and lifestyle modifications for reflux are essential. PPIs may heal esophagitis and may even reverse esophageal fibrosis. 55 Higher than standard doses of PPIs may be needed but likely do not prevent progression of dysmotility. 56 Whether PPIs help pulmonary disease is not known. Prokinetic agents may help in the early stage of disease. Buspirone, a 5-HT1 receptor agonist, may have a favorable effect on esophageal peristalsis and lay function. An open-label trial of buspirone 20 mg daily in 30 PPI refractory patients with PSS showed a significant increase in resting lay pressure and significant reductions in heartburn and regurgitation scores at 4 weeks. 57 Surgical therapy with fundoplication has a limited role due to concern that dysphagia could worsen in an peristaltic esophagus. 43 A Roux-en-Y gastric bypass is an alternative. 58 Gastric involvement. Gastric emptying, particularly for solids, is often delayed in PSS and may result in early satiety, bloating, nausea, and vomiting or may be asymptomatic. 59,60 Gastric outlet obstruction and PUD, especially in the presence of NSAIDs, should be ruled out. EUS may show thickening of the gastric wall, particularly the submucosa and muscularis. 61 Treatment of delayed gastric emptying has not been extensively studied in PSS. 62 Gastric enteral vascular ectasia may be found. Small bowel involvement. The true prevalence of small bowel dysfunction is unknown. The absorptive capacity is normal except with SBBO or the rare association with celiac sprue. 63 Small bowel permeability may be increased in PSS, resulting in protein-losing gastroenteropathy, PLGE, or generalized malabsorption. 64 In severe cases, intestinal failure requires intravenous nutrition and has a poor outcome. Delayed orocecal transit time is common. 65 Manometric abnormalities of the small bowel are frequent. 66,67 Absent, abnormal, or uncoordinated migrating motor complexes suggest a neuropathic process, whereas reduced amplitudes of contraction may suggest a myopathic process. The small bowel may be dilated with flocculation and pooling of barium. A hidebound bowel consists of diffuse dilatation with closely packed valvuli connivents from atrophy of the longitudinal fibers of the muscularis propria that foreshortens the bowel. 68 The jejunum and colon may have true diverticula containing all of the layers of the bowel wall, with wide necks that do not predispose to diverticulitis. 60 They may be asymptomatic or associated with abdominal pain, vomiting, bleeding, perforation, or SBBO. Rarely, pneumatoses cystoides intestinalis, see Fig 37.1, intestinal pseudoobstruction, or pneumoperitoneum may develop. 69,70 SBBO is common. 71 and due to delayed orocecal transit time, loss of normal migrating motor complexes, presence of diverticula, and raised gastric pH with PPIs. Symptoms may improve with antibiotics, sometimes in combination with daily low-dose octreotide, which may improve phase 3 of the migrating motor complex in PSS patients. Colonic involvement in PSS is common but frequently asymptomatic. Symptoms include abnormal stool consistency, bloating, incomplete evacuation, fecal incontinence, and rectal bleeding. 72 Typical findings on barium enema include an increase in luminal fluid, post-evacuation residuals, and lack of haustrations with dilatation. 60 Complications of colonic involvement include pseudoobstruction, stercoral rectosigmoid ulcers from chronic impaction, volvulus, perforation, colonic strictures, rectal prolapse, pneumatoses cystoides intestinalis, and benign pneumoperitoneum. 59,60 Oral mineral oil should be avoided in those with impaired esophageal function and at risk for aspiration. Osmotically active agents may worsen pseudoobstruction. Data on prokinetics are limited. A report describes successful use of prucalopride, a 5-HT4 receptor agonist, in 2 PSS patients, but further studies are needed. 73 Octreotide may be useful in refractory cases and can be tried in combination with erythromycin. 74,75 Anal involvement incontinence of feces is due to diarrhea, anal dysfunction, rectal prolapse, and chronic straining. The internal anal sphincter, IAS, composed of smooth muscle, is atrophic and thin as shown by endoanal ultrasonography and functional lumen imaging probe. 76,77 Resting anal sphincter tone may be reduced, the anal sensory threshold attenuated, rectal compliance reduced, and the rectoanal inhibitory reflex impaired. 78,79 Treatment includes biofeedback, often unsuccessful, and sacral nerve stimulation, although data are limited. 80 Similar to gastric antral vascular ectasia, patients may develop watermelon-like vascular stripes in the rectum, with dilated and thrombosed capillaries in the lamina propria. 81 In addition, telangiectasias have been described throughout the GI tract and may be sources of bleeding. Miscellaneous problems case reports document idiopathic calcific pancreatitis and arteritis resulting in ischemic pancreatic necrosis. 60,82 Anti-centromere antibody, a hallmark antibody of PSS, is reported in 9% to 30% of patients with PBC, and 25% of PSS patients are positive for AMA. Patients with PBC associated with PSS have slower liver disease progression compared to those with PBC alone. 12,13,83 Systemic lupus erythematosus SLE is a multisystemic autoimmune disorder. 84,85 GI symptoms, e.g., nausea/vomiting, anorexia, abdominal pain, are common but usually mild. In adults, they are caused by diverse etiologies, sometimes unrelated to lupus, with wide ranges of severity. In children, abdominal pain is usually related to the SLE, most commonly from vasculitis, pancreatitis, and/or peritonitis/ascites. 86,87 Vasculitis, also termed lupus enteritis when pathology is unavailable, affects up to 9.7% of patients with SLE and up to 65% of those presenting with an acute abdomen. 88 The inflammatory form is characterized by leukocytoclastic vasculitis due to immune complex deposition in vessel walls, whereas the thrombotic form is caused by thrombosis of vessels associated with antiphospholipid antibodies. These processes may activate one another. Its presentation, ranging from mild symptoms to an acute abdomen, is almost always accompanied by systemically active disease. 88-90 There is usually pain, nausea, and vomiting, tenderness. Chapter 37 Gastrointestinal and Hepatic Manifestations of Systemic Diseases 537-37 Hypocomplementemia, and leukopenia. Complications include symptomatic ischemia, infarction, stricture formation, bleeding, and perforation. CT findings typically include bowel wall thickening, target or double halo sign, dilatation of intestinal segments, comb sign, prominent mesenteric vessels with palisade pattern, ascites, or in more advanced cases, pneumatosis intestinalis or mesenteric venous gas. 91 The jejunum and ileum are most commonly affected, with involvement being segmental or multifocal rather than restricted to a vascular territory as in thromboembolic ischemia. 89 Mesenteric angiography, although useful in excluding polyarteritis nodosa, PAN, may be negative in SLE, which generally involves medium to small arteries. Endoscopic exams may show ischemia and punched-out ulcers with intervening normal mucosa, although colonoscopy can occasionally precipitate ischemic colitis and/or perforation. 92 Endoscopic biopsies are often unrevealing unless submucosal vessels are sampled. Pathology shows small vessel arteritis and venulitis, leading to diffuse concentric fibrosis, fibrinoid necrosis with thrombosis of affected vessels, leukocytoclasis, and inflammatory infiltrates. 88 Patients usually respond well to glucocorticoids. 88,89 Although cyclophosphamide can be used in difficult cases. The differential diagnosis includes antiphospholipid antibody syndrome and opportunistic infections, which may mimic GI vasculitis in these immunocompromised patients. 93 Esophageal, gastric, and intestinal involvement. SLE esophageal involvement manifests as heartburn and sometimes dysphagia exacerbated by esophageal dysmotility and decreased saliva production from associated SS. Dysmotility has been found in different parts of the esophagus, although it is less frequent than in PSS or mixed connective tissue disease, MCTD. 94 The upper esophagus and pharynx may be involved. Whether this is due to SLE or to an overlap with polymyositis is controversial. Also seen is a peristalsis in the lower esophagus with a hypotonic less, due to SLE itself or PSS/MCTD overlap. Gastric involvement manifests as dyspepsia. It is unclear whether lupus confers an additional or synergistic ulcerogenic effect above that seen with NSAIDs and/or glucocorticoids. Patients with SLE may have low serum B12 levels, intrinsic factor antibodies, or, rarely, pernicious anemia. 84,85 Although hypoalbuminemia in SLE is usually ascribed to nephrotic syndrome, disease exacerbation, liver disease, and excess intestinal losses should be kept in mind. PLGE, sometimes an initial manifestation of SLE and often found in young women, is characterized by marked hypoalbuminemia, ascites, pleural or pericardial effusions, peripheral edema, and low serum complement levels. 95-97, GI symptoms such as abdominal pain or diarrhea may be infrequent. The source of protein loss is usually the small bowel and, less commonly, the colon. 96 Possible mechanisms include increased microvascular/endothelial permeability, complement-mediated vascular injury, and vasculitis. Other causes of PLGE and SLE include pericardial effusion/constriction and SBBO, see Chapter 31. A relationship between SLE and celiac disease has been suggested in the past. Although a threefold increased risk of SLE has been reported in patients with celiac disease, this translates into a low absolute risk of at most 2 individuals in 1,000 developing SLE in 10 years. 98 SLE has been described with IBD, eosinophilic enteritis, and collagenous colitis. These may represent chance associations. 84,85,99 Immunocompromised SLE patients may acquire CMV that could mimic a lupus flare with enteritis and/or pancreatitis. 100,101 Salmonellosis is also a common infection in SLE.102,103 bacteremia with fever and abdominal pain is seen more frequently than diarrhea, and the organism is more commonly isolated from blood than stool. Risk factors include immunosuppression, low complement levels, impaired clearance of the organism, and hyposplenism. SLE and salmonellosis share certain clinical features such as pleurisy, synovitis, cytopenias, and rashes. An increased incidence of giardiasis in SLE patients compared with healthy controls has been suggested. 104 Pneumatosis cystoides intestinalis, see Fig 37.1, and pneumoperitoneum are rare, generally benign lesions associated with SLE. 105 Intestinal pseudoobstruction, see Chapter 124, usually occurs in the setting of active lupus, sometimes as an initial manifestation of disease, and has many proposed etiologies. It is associated with ureterohydronephrosis and interstitial cystitis. 84,106,107 Patients often respond to glucocorticoids. Pancreatic and gallbladder involvement. The annual incidence of SLE-associated pancreatitis is said to be 0.4 to 1 per 1,000 in SLE patients. 108 But subclinical cases may be missed, and other causes of pancreatitis are common in SLE. 109 In about 22% of cases, pancreatitis is the initial presentation. Patients usually have active lupus. 110 Only an occasional patient will have vascular lesions associated with antiphospholipid antibodies. 108 Glucocorticoids reduce mortality. 108 Addition of azathioprine may be needed. Chronic pancreatitis is extremely rare, is usually preceded by episodes of acute pancreatitis, and is not associated with exocrine or endocrine pancreatic insufficiency. 111 Primary sclerosing cholangitis and autoimmune cholangiopathy have been found in patients with SLE. 84,112 Pronounced irregularity of the common bile duct may be due to previous subclinical vasculitic episodes affecting the delicate intramural capillary network. Acute acalculous cholecystitis may be due to vasculitis or thrombosis. 113 Although usually treated surgically, it may respond to glucocorticoids if the gallbladder is not distended and if there is no evidence of septicemia. Ascites and peritonitis. SLE predisposes to ascites from many causes, such as infection, heart failure, bowel infarction, nephrotic syndrome, PLGE, constrictive pericarditis, pancreatitis, mesenteric vasculitis, Budd-Chiari, or serositis. 114 Serositis more commonly presents as pleuritis or pericarditis rather than peritonitis. 115 In acute lupus peritonitis, the ascites tends to develop rapidly and is associated with pain and a lupus flare. In chronic peritonitis, the ascites develops slowly and is painless. The sterile acidic fluid may show a low complement level, positive ANA, elevated anti-DNA antibody, and typically a low, 1.1 g/dl, serum ascites albumin gradient. Peritonitis may respond to glucocorticoids or may require additional immunosuppressive therapy. Hepatic involvement. Abnormal liver chemistry tests are common, but end-stage liver disease is rare. 13,116 Multiple etiologies of liver disease are found, e.g., fatty liver, hepatic arteritis, PBC, AIH, nodular regenerative hyperplasia, viral hepatitis, drug reaction discussed previously under RA. Hepatitis from SLE, considered a variant of AIH by some investigators, is associated with antiribosomal P antibodies. 12,13,84,116 HCV can mimic SLE clinically and serologically. 117 An interferon treatment can induce SLE. 118 Infliximab induces ANA and anti-double-stranded DNA in 53% and 35% of patients with IBD, but drug-induced lupus is rare. 119 Vascular disorders of the liver include Budd-Chiari syndrome and hepatic infarction, often due to antiphospholipid syndrome. 12,13,120 Focal disturbances of the hepatic blood supply may account for an increased frequency of focal nodular hyperplasia and hepatic hemangiomas in SLE patients. 538 Part 4 Topics involving multiple organs. Myopathies. The inflammatory myopathies polymyositis, dermatomyositis, and inclusion body myositis are diagnosed by a combination of muscle weakness, elevated muscle enzyme levels, electromyographic evidence of a myopathy, and typical muscle histology. 121 Serum AST and ALT levels are roughly equal, because the greater release of AST is counteracted by its greater clearance. 122 Often, an ALT of 100 U/L is accompanied by creatine phosphokinase levels of about 1000 U/L. 123 Although many exceptions occur. Of the drugs used in GI diseases, myositis can be caused by anti-TNF agents, interferon, and occasionally PPIs. 124 Myositis can also be associated with IBD, celiac disease, infection with HBV or HCV, and PBC. 121,125 Dermatomyositis may also be associated with a GI vasculopathy, a grave but rare manifestation, resulting in vascular ectasias, ulcers, and bowel perforation. 126 Dermatomyositis and, less commonly, polymyositis may be paraneoplastic associated with malignancy involving the stomach, colon, pancreas, and other organs. Involvement of the pharynx and upper esophageal sphincter, UES, both composed of skeletal muscle, results in nasal regurgitation, tracheal aspiration, tongue weakness, and dysphagia for both solids and liquids. 127,128 Low amplitude pharyngeal contractions and decreased UES pressure are found on esophageal motility studies. Smooth muscle may also be involved, with delayed esophageal and gastric emptying. 121 Reduced lay pressure and non-peristaltic low amplitude simultaneous esophageal contractions are associated with heartburn. Treatment of esophageal disease includes immunosuppressive therapy, e.g., glucocorticoids, intravenous immunoglobulin, cricopharyngeal myotomy, and pharyngeal dilatation, resulting in variable success rates. 127,128 Sjogren syndrome SS occurs alone, primary, or associated with an autoimmune disease, secondary. SS is characterized by lymphocytic infiltration of lacrimal and salivary glands with keratoconjunctivitis sicca and xerostomia. The mouth, discussed in Chapter 24, and esophagus are most commonly involved. 129 Reduced salivary neutralization may increase esophageal acid exposure time and predispose to reflux symptoms and/or mucosal damage. Although salivary flow rates are reduced and a variety of motility disturbances may be found in the esophagus, neither of these abnormalities generally correlates with dysphagia. 129,130 Although chronic atrophic gastritis is common, low vitamin B12 levels and/or pernicious anemia are rare. 129 Whether the prevalence of HP gastritis is increased in SS is controversial. Treatment of HP does not reduce gastric lymphocytic infiltration, atrophy, or dyspepsia. 131,132 There is a well-known association with mucosa-associated lymphoid tissue lymphoma. Gastric lymphoma is the most common extraglandular site for lymphoma in SS. A risk for gastric adenocarcinoma has been suggested, which may parallel the disease severity association with inflammatory markers, IgA level and SSB antibody. The role for gastric cancer screening or surveillance in SS is unclear. Associated celiac disease is found in up to 15% of SS patients. 133 Pancreatitis has been documented in up to 7% of patients with SS. 129 Often presenting as autoimmune pancreatitis. 134 Or chronic pancreatitis. Chronic pancreatitis, with morphologic changes and/or an abnormal secretin test, may occur in about 25% of patients with SS. 135 but is usually clinically silent. Abnormal liver chemistry tests, found in 10% to 49% of SS patients, are usually mild and have no definite pattern and little clinical significance. 136,137 Hepatomegaly occurs in 11% to 21% of patients. 129 The most common causes of liver disease are non-alcoholic fatty liver disease, PBC, AIH, and HCV. Sicca syndrome, abnormal salivary histology, and abnormal sialograms are common in PBC, whereas anti-SSA/B antibodies are not. Although xerostomia, decreased salivary flow rates, and sialidinitis are seen in HCV, Anti-RO/SSA/B antibodies are rare. 138 The pathogenesis of HCV-related SS may be due to HCV infection of salivary glands, molecular mimicry, and/or the formation of immune complexes containing HCV. 129 Mixed connective tissue disease MCTD is an overlap syndrome including characteristics of SLE, PSS, and polymyositis associated with antibodies to ribonucleoprotein. Patients can present with heartburn and dysphagia. 139 Delayed esophageal transit, pathologic gastroesophageal reflux on 24-hour pH study, and reduced amplitude and coordination of esophageal peristalsis are found in the majority of patients. 139-141 The diagnosis of MCTD is suggested if there is dysmotility of the entire esophagus, both upper and lower, similar to that seen in polymyositis and PSS, respectively. Like in PSS, esophageal abnormalities usually correlate with pulmonary abnormalities in MCTD. 139-140 The role of glucocorticoid therapy in esophageal disease is uncertain. Changes similar to those of PSS may be seen in the intestine. 142 Occasionally patients may have a vasculitis, amyloidosis, or pancreatitis. 143 There may be hepatomegaly, splenomegaly, AIH, idiopathic portal hypertension. 144 or Budd-Chiari syndrome. Polyarteritis nodosa. PAN is a vasculitis affecting mainly medium-sized arteries. It causes necrotizing inflammation, fibrinoid necrosis, neutrophilic infiltration, and fibroblast proliferation of the vessel wall. 145-146 Arterial aneurysms, stenosis, thrombosis, occlusion, and rupture of the artery occur. The result is impaired intestinal perfusion, ulcerations, bleeding, and ischemia if damage is limited to the mucosa or submucosa, and perforation if there is transmural involvement. The entire GI tract may be involved, but small bowel involvement is most common. 147 Liver involvement, usually subclinical, includes necrotizing vasculitis leading to atrophy of a liver lobe, liver infarction, or nodular regenerative hyperplasia. 148 Rarely, aneurysmal rupture occurs in the liver resulting in hemophilia, subcapsular hemorrhage, or intrahepatic hemorrhage. HBV-associated PAN, which generally occurs early in HBV infection, has a higher association with GI disease, more severe vasculitis, and a higher mortality rate than PAN without HBV. 145-146 HBV PAN is characterized by circulating immune complexes containing hepatitis B surface antigen and anti-hepatitis B surface antibodies, supporting the concept that it is mediated by deposition of viral Ag/Ab complexes. Hepatitis B is silent in most cases, with only mild increases in serum aminotransferases. 149 HCV can occasionally be associated with PAN, but unlike the early onset after HBV exposure, PAN usually occurs several years after viral exposure. Like HBV PAN, it usually manifests with severe vasculitis. 150 Pancreatic involvement occurs in 35% to 37% of autopsy cases, with acute pancreatitis, pancreatic infarcts, pseudocysts, pancreatic masses, or pancreatic insufficiency. 145 Vasculitis of arteries supplying small bile ducts leads to intrahepatic sclerosing cholangitis, whereas cystic arteritis leads to acalculous gangrenous cholecystitis. 147-151 Ascites due to vasculitis is rare. 152 Angiography, which is abnormal in more than 60% of patients. 153-154 shows arterial aneurysms, irregularities, and thrombosis, all of which may progress to stenosis and occlusion of the vessels. Aneurysms are focal and segmental, in different stages of development, with a predilection for branch points of vessels. They tend to be multiple, intraparenchymal, and measure up to 1 cm in diameter. Rupture, especially in the presence of hypertension, occurs occasionally. Microaneurysms are Chapter 37 Gastrointestinal and Hepatic Manifestations of Systemic Diseases. 539-37 Sometimes seen as in other conditions, e.g., RA, SLE, granulomatosis with polyangiitis. A normal visceral angiogram does not exclude PAN. Aneurysms may be thrombosed or healing. CT may show bowel wall thickening and the target sign. 155 Three-dimensional CT angiography detects aneurysms with diameters as small as 3 mm, as well as early vasculitic changes such as increased wall thickness and calcification, not seen on routine angiography. Biopsy sites include skin lesions, sural nerve, and muscle. Endoscopic biopsies are usually too superficial to make the diagnosis. Deeper biopsies risk perforation. 147 Glucocorticoids, along with a potent immunosuppressive agent, particularly cyclophosphamide, dramatically decrease mortality. HBV-PAN or HCV-PAN are usually treated with immunosuppressive agents and an antiviral agent, sometimes with plasma exchanges, to remove immune complexes. 145, 146, 149 Hainoxline purpura. Hainoxline purpura, HSP, is the most common systemic vasculitis in childhood, and occasionally affects young adults. HSP is clinically characterized by palpable purpura, arthritis, as well as renal and GI involvement. Adults typically have a more severe clinical syndrome with higher frequency of renal involvement. HSP is mediated by immune deposits, typically IgA, resulting in leukocytoclastic vasculitis that causes necrosis of small blood vessel walls. 156-158 GI involvement occurs in the majority of patients and sometimes precedes the rash. The abdominal pain is usually colicky, periumbilical, or epigastric, sometimes worsening with eating. There is occult or, less commonly, overt, usually melenic bleeding, usually melena. The small intestine is most frequently involved, with the second portion of the duodenum involved more than the bulb. 156-158 The main differential diagnosis is Crohn's disease. Intussusception is usually ilioileal or ileocolic and due to an ileal lead point, intramural hemorrhage or edema. It often resolves spontaneously or may be reduced with air or contrast enemas performed gently to minimize perforation risk. 159 If intussusception is still present after 24 hours, surgery should be considered. Rarely, the patient may develop acute acalculous cholecystitis, ascites with serositis, or pancreatitis. 156 Recurrences are usually stereotypic, milder, and shorter in duration than the first episode. Endoscopic findings include petechiae, erosions, and ulcers, hyperemia, and ecchymoses, Fig 37.3. Mucosal biopsies usually show IgA deposition and inflammation. Sampling of the submucosa may reveal vasculitis. Capsule endoscopy may determine the extent of disease and location of bleeding. 160 CT shows thickened bowel walls with skip lesions, ileus, and bowel dilation. To avoid irradiation in children, abdominal ultrasonography is considered the study of choice by some and may help determine prognosis. 161 Glucocorticoids should be considered in those at high risk for renal involvement. Their effects on GI disease are unknown, as more than 80% of cases resolve spontaneously. 156-162 Other modalities, plasma exchange, dapsone, and intravenous immunoglobulins, have been tried. Eosinophilic granulomatosis with polyangiitis. Eosinophilic granulomatosis with polyangiitis, formerly Churg-Strauss syndrome, is a small and medium vessel vasculitis with GI involvement in up to 59% of cases. 163 Of the three phases of this disease, prodromal, eosinophilic, and vasculitic, the GI tract can be involved in the last two. An eosinophilic gastroenteritis can occur with peripheral eosinophilia and an eosinophilic infiltrate in the GI mucosa. 163-164 Abdominal pain, diarrhea, nausea/vomiting, and bleeding are the most common symptoms. Vasculitis may cause ulcerations, perforation, and rarely stenosis. 165 The ulcers characteristically have an erythematous rim. 166 Unusual complications include acalculous cholecystitis, pancreatitis, or eosinophilic ascites from involvement of the peritoneum. 164 Intestinal resection specimens and submucosal biopsies reveal vasculitis with fibrinoid necrosis, eosinophilic infiltrates, and/or granulomas. Glucocorticoids achieve remission in 90%, but close monitoring for intestinal perforation is needed. Glucocorticoid refractory disease may be treated with cyclophosphamide, intravenous immunoglobulin, or plasma exchange. 167 Severe GI tract involvement is associated with a poor outcome. Granulomatosis with polyangiitis. Most of the GI tract can be involved in granulomatosis with polyangiitis, which is a necrotizing vasculitis affecting small and medium-sized vessels. The incidence of GI involvement is difficult to determine as it is often asymptomatic. Oral involvement includes ulcers, lingual infarction, and the pathognomonic strawberry gums, representing gingival hyperplasia studded with petechiae like a ripe strawberry. 168 Esophageal and gastric ulcers occur, with pathology showing necrotizing granulomatous inflammation. 169 Vasculitis leads to intestinal ulcerations, ischemia, infarction, strictures, and perforation. It may resemble or be associated with IBD. 170 Arteritis may lead to pancreatitis or a gangrenous gallbladder. 171 Liver involvement is usually nonspecific, although unusual findings, such as incomplete septal fibrosis from ischemia, have been described. 172 Superficial intestinal biopsies may reveal only nonspecific findings, and angiography may be normal. Paranuclear staining antibody ANCA, p-ANCA, specific for myeloperoxidase may be positive, but the cytoplasmic staining antibody ANCA, c-ANCA, directed at the proteinase 3 antigen of myeloid lysosomes, PR3, is more specific. Most lesions respond to immunosuppression, such as with cyclophosphamide. Cryoglobulinemia. Cryoglobulins are immunoglobulins that precipitate in vitro at temperatures below 37 degrees C. 173 Cryoglobulinemia may produce organ damage through hyperviscosity or vasculitis, the latter being the main mechanism for GI involvement. Although cryoglobulinemia is associated with infections, autoimmune diseases, and cancer, the most common cause is HCV. Up to 7% of patients with cryoglobulinemia have GI involvement, usually manifesting Fig 37.3 endoscopic views in a patient with Haynoxian line purpura. The upper views show jejunal mucosa that is diffusely thickened and nodular with superficial linear ulcers, black arrow. The lower views show ileal mucosa with a cobblestone appearance. From Ebert E.C. Gastrointestinal manifestations of Haynoxian line purpura. Dig Dis Sci 2008, 53:2011-19, with permission from Springer. 540 Part 4 Topics involving multiple organs as mesenteric vasculitis, CRA, SLE, and PAN. 174 Severe GI involvement is an independent factor associated with poor outcome in non-HCV-related vasculitis. Treatment is aimed at the underlying disease and may include immunosuppressive drugs, apheresis, and/or rituximab. Behçet disease. This multisystemic vasculitis typically includes recurrent oral and genital ulcers, arthritis, and characteristic skin lesions. CNS symptoms, GI lesions, hypercoagulability, and visceral artery aneurysms may also be seen. Although Behçet disease, BD, is most common in the ancient Silk Road countries, GI involvement in this disease is most common in certain other countries, e.g., Japan, United Kingdom. 175,176 Small vessel vasculitis primarily affecting veins and venules. Presence with mucosal inflammation causing ulcers. Large vessel disease results in ischemia and infarction. This vasculitis mainly affects the ileocecal region, resembling Crohn's disease. Extraintestinal manifestations of oral apathy, uveitis, arthritis, and erythema nodosum may mimic IBD. Several features distinguish BD from Crohn's disease. 177-179 Unlike Crohn's disease, BD rarely causes strictures, perianal disease, or rectal ulcers, and multisegmental or diffuse GI involvement is rare. BD frequently causes oral ulcers, mucosal edema, intestinal perforation, and venulitis, without bowel inflammation, fibrosis, or granulomas, and it often resolves spontaneously. Infectious processes may mimic or complicate BD. 180 Endoscopic studies should be done with caution due to a risk of perforation, because the intestinal ulcers are often quite deep. There may be amyloidosis, discussed later, aneurysm formation, or hepatic or portal vein thrombosis. 181 Thrombophlebitis, thought to be due to venulitis, may not benefit from anticoagulation. Acute pancreatitis, Budd-Chiari syndrome, multiple aseptic hepatic and splenic abscesses 182 and sclerosing cholangitis are reported in BD. Therapy of GI involvement includes mesalamine, immunomodulators, and TNF inhibitors. Whether glucocorticoids prolong the healing process and provoke perforation is unclear. 183 A phase 2 study found that the oral phosphodiesterase inhibitor apremilast significantly reduced oral ulcer formation in patients with BD. However, the treatment was brief, 12 to 24 weeks, and associated with diarrhea and with nausea and vomiting. Furthermore, effects of apremilast on other aspects of the disease, including the GI manifestations, remain to be elucidated. 184 Recurrences after surgery, often at the anastomotic site, occur in 50%. 185 Spondyloarthropathies. Subclinical gut inflammation has been described in up to 2/3 of patients with various spondyloarthropathies. 186-188 The presence of ileitis may be associated with chronicity of the articular disease. The acute form of spondyloarthropathy, typically reactive arthritis, has gut inflammation that mimics bacterial enteritis with neutrophil infiltration but preserved gut architecture. The chronic form, typically ankylosing spondylitis, mimics Crohn's disease, with a mononuclear cell infiltrate and disturbed architecture. Although it may be histologically indistinguishable from Crohn's ileitis, spondyloarthropathy-associated ileitis is usually asymptomatic, radiologically inapparent, and patients are usually HLA-B27 positive. Ankylosing spondylitis is found in up to 15% of IBD patients in general and in 50% of IBD patients with HLA-B27. For axial involvement, NSAIDs reduce joint pain and stiffness but may worsen underlying IBD. Glucocorticoids are rarely effective in spondyloarthropathies and decrease bone mineral density. Sulfasalazine and possibly methotrexate may have some efficacy in spondyloarthropathies, particularly in patients with appendicular involvement. TNF-alpha blocking agents, including etanercept, which is not used in IBD, are also quite effective. Familial Mediterranean fever, FMF, an autosomal recessive disease, is characterized by recurrent self-limited attacks of fever, joint pain, and abdominal pain, most commonly in people of Mediterranean origin. 189-190 The gene responsible for FMF, MEFV on chromosome 16, encodes the protein pyrin. MEFV gene analysis assists in diagnosis. Patients develop what appears to be an acute abdomen due to peritonitis. Their severe abdominal pain is reduced by lying motionless with hips flexed. The abdomen is rigid with rebound tenderness, reduced bowel sounds, and abdominal distension. There may be multiple air fluid levels, a leukocytosis with a left shift, an increased ESR, and elevated acute phase reactants. The attack begins to subside after 24 hours. Peritonitis results in protein-rich sterile exudates with fibrin and neutrophils that, when organized, may lead to adhesions and small bowel obstruction, sometimes with strangulation and necrosis. Patients are asymptomatic between episodes, although acute phase reactants may be elevated, indicating subclinical inflammation. Serum amyloid concentration increases dramatically during febrile attacks. See amyloidosis under infiltrative diseases. AA amyloidosis may develop independent of the frequency, duration, and intensity of flare UPS. Kidney impairment is the most clinically significant result, but amyloid can deposit in the GI tract and cause symptoms after many years. FMF is associated with other diseases such as IBD 191, some vasculitides, and irritable bowel syndrome. GI mucosal involvement may suggest IBD, but mucosal healing can be achieved with colchicine alone. Abnormal esophageal motility may occur regardless of amyloid status. 192 Liver disease is usually from amyloid, and splenomegaly is from ongoing inflammation. 189-190 Although there is no specific treatment for acute attacks, colchicine reduces the attack frequency, severity, and duration in most FMF patients. Because it can prevent, arrest, and even reverse renal amyloidosis, colchicine should be continued for life. Refractory cases may respond to the anti-IL-1 beta-1 monoclonal antibody canakinumab. Disorders of connective tissue GI manifestations have been reported in a variety of connective tissue disorders. These may be classified as structural or functional abnormalities. GI manifestations in Marfan syndrome are typically overshadowed by cardiac, ophthalmic, and musculoskeletal manifestations. Fibrillin-1 gene mutations lead to qualitative and/or quantitative alterations to the glycoprotein fibrillin-1, with subsequent myofibril deficiency and connective tissue instability. In the GI tract, this may lead to visceral herniation, abdominal wall hernias, diverticula/pseudodiverticula, and clinical events such as acute appendicitis or acute diverticulitis at unusually young ages. There also appears to be an increased frequency of hepatic cysts, renal cysts, and cholelithiasis. Functional GI disorders such as IBS may also be more common than in control groups. 193 In Ehlers-Danlos syndrome, EDS, functional GI disorders predominate but epiphrenic diverticula, diaphragmatic event ration, megaesophagus, spontaneous GI perforations, and acute GI bleeding may occur. One large retrospective study found that 378 of 687 patients with EDS, 56%, had associated GI manifestations in the classic, hypermobility, and vascular subtypes. The vascular subtypes all had frequent GI symptoms, but such symptoms were somewhat less common than in the hypermobility variant. Typical symptoms included abdominal pain, 56%, nausea, 42%, constipation, 39%, heartburn, 38%, and IBS symptoms, 28%. Gastric and colonic transit were delayed in 12% and 28%, respectively. All abdominal aneurysms occurred in the EDS vascular subtype. 194 The benign joint hypermobility syndrome may be found with increased frequency in unselected tertiary functional GI disorder. Chapter 37 Gastrointestinal and hepatic manifestations of systemic diseases. 541 37 patients when compared with a 10% to 20% frequency in normal individuals. Joint hypermobility incidence was evaluated in 129 unselected new tertiary referrals, 97 female, to a neurogastrointestinal clinic, and 63, 49%, had evidence of joint hypermobility. An unknown etiology of GI symptoms was more frequent in those with joint hypermobility than in those without it. A clinical impression of joint hypermobility was confirmed by a rheumatologist in 23 of 25 patients evaluated. 195 IgG4-related disease. This rare multi-system inflammatory and fibrotic disorder typically affects the pancreas, type I or II autoimmune pancreatitis, see Chapter 59, or bile ducts, and can mimic pancreatic cancer, cholangiocarcinoma, or PSC. Reports of other intra-abdominal involvement include retroperitoneal fibrosis, aortitis, sclerosing mesenteritis, inflammatory pseudotumor, hepatitis, enteritis, colitis, and pouchitis. Serum IgG4 is elevated in only 60% to 70% of patients. Frequently, diagnostic biopsies of the affected organ are necessary and typically reveal a dense lymphoplasmacytic IgG4 staining infiltrate, storiform fibrosis, and obliterative phlebitis. Glucocorticoids are usually effective therapeutically, and maintenance immunomodulators are sometimes required. Oncologic and hematologic diseases. Metastases to the gastrointestinal tract. Metastases to the gut occur by hematogenous or lymphatic spread or by intraperitoneal seeding, most commonly from breast cancer. 196 Metastases are distinguished from primary tumors by the absence of a transition between normal and cancer cells, and by histologic and immunohistochemical similarities between the primary and the secondary deposits. GI metastases are more commonly seen at autopsy than clinically, because many are asymptomatic. The most common presentations are abdominal pain, anemia, GI bleeding, obstruction, weight loss, and, rarely, PLGE. 196,197 Some metastases, particularly melanoma, Fig 37.4, breast cancer, and renal cell carcinoma, may present decades after the primary tumor is found. 198,199 Polypoid metastatic lesions in the intestinal mucosa may initiate intussusception 200 or result in bleeding from ulceration or cavitation as the growth of the metastasis exceeds its blood supply. Deposition in the submucosa causes a submucosal mass or diffuse infiltration with wall thickening and rigidity. With central ulceration, a bullseye lesion may appear. 198,201 Carcinomatoses with malignant ascites may occur with rupture of tumor into the peritoneal cavity. 198 Perforation may occur, sometimes from tumor necrosis caused by chemotherapy. Gastric metastases are most commonly from lung, breast, esophagus, and melanoma. 201 Small bowel involvement is most commonly due to lobular breast cancer or malignant melanoma. Pancreatic metastases are rare and due to renal cancer in 60% of cases. 202 Renal cancer appears as an enhancing mass on CT and is hypervascular on angiography. 203 Resection of a pancreatic metastasis may increase survival. 202,203 Melanoma metastases, pigmented or amyloidic, are most often found in the small bowel. 198,199 Surgical resection of the metastasis, usually for anemia or obstruction, improves symptoms with minimal morbidity or mortality, although disease recurrence is common. Postoperatively, melanoma is the most common primary site to lead to gallbladder metastases. 204 The most common type of breast cancer to metastasize to the GI tract is lobular carcinoma, even though most breast cancers are ductal carcinomas. 205 Patients occasionally present with oropharyngeal dysphagia, pseudoachalasia, or an esophageal stricture. Gastric metastases may mimic linitis plastica with an infiltrative picture, involvement of the terminal ileum may resemble Crohn's disease, and rectal infiltration may mimic primary rectal cancer, Schnitzler metastasis. Metastatic breast cancer may consist of signet ring cells without gland formation, mimicking a primary GI malignancy. Estrogen receptors are commonly expressed in the tumor, helping in the diagnosis. GI metastases from lung cancer, although rare, are usually due to large cell carcinoma. 206 Paraneoplastic syndromes. Paraneoplastic GI dysmotility presents with pseudoachalasia, gastroparesis, or pseudoobstruction. 207,208 It is most commonly due to small cell lung cancer, with GI symptoms usually preceding the tumor diagnosis by weeks or months. Other primary neoplasms associated with paraneoplastic GI dysmotility include breast, bladder, prostate, kidney, testicular, ovary, neuroblastoma, and primary GI malignancies such as pancreatic carcinoma. The most commonly described autoantibodies are type 1 antineuronal nuclear antibodies reactive against tumor cells and neuronal nuclei, including those in the myenteric plexus. Anti-HUD antibodies induce neuronal apoptosis. 209 The presence of this and similar antineuronal antibodies should prompt a search for malignancy. Neuropathy is the most common manifestation of type 1 antineuronal antibodies, but GI dysmotility is found in about 30% of patients. Patients present with acute and rapidly progressive weight loss, dysphagia, nausea and vomiting, early satiety, constipation, and or abdominal pain, usually with normal chest X-rays despite the presence of small cell lung cancer. 208 Esophageal dysmotility, delayed gastric emptying, slow intestinal transit, and abnormal autonomic reflex tests are common. 210 Antraduodenal manometry shows a neuropathic type of GI dysmotility. The differential diagnosis of altered GI motility includes viral infections, medications, especially opioids, chemotherapy, e.g., vincristine, and radiation damage. Conventional therapeutic measures, such as prokinetics, antiemetics, and laxatives, have limited benefit. 208 Even chemotherapy that shrinks the tumor may not palliate the GI symptoms. Paraneoplastic hepatopathy describes the rare phenomenon of intrahepatic cholestasis as a paraneoplastic phenomenon, most commonly associated with renal cell carcinoma, Stauffer syndrome, and lymphoma. Alkaline phosphatase abnormalities are most characteristic and hyperbilirubinemia or jaundice is more unusual. Paraneoplastic hepatopathy has also been associated with pheochromocytoma, prostate carcinoma, Medullary thyroid Fig 37.4 Endoscopic view of an ulcerated metastatic melanoma lesion involving the second portion of the duodenum in a young man who presented with upper GI bleeding. 542 Part 4 Topics involving multiple organs: carcinoma, ovarian dysgerminoma, and neuroendocrine tumors. Such cholestasis has been associated with nonspecific hepatic inflammation or sinusoidal dilation histologically, typically resolves after tumor resection, and may recur with tumor recurrence. Paraneoplastic biliary ductal damage, secondary sclerosing cholangitis, and the vanishing bile duct syndrome have been associated with lymphoma. 211 Poems syndrome, polyneuropathy, organomegaly, endocrinopathy, M-protein, skin changes, is a rare multi-system neoplastic disorder of plasma cells. It frequently has an insidious onset manifesting in the 5th to 6th decade of life. Mandatory criteria include polyneuropathy and a monoclonal plasma cell dyscrasia, usually lambda light chain. Major criteria may also include Castleman disease, sclerotic bone lesions, and vascular endothelial growth factor, VEGF, elevation. Minor criteria include organomegaly, extravascular fluid accumulation, edema, low SAAG 75% ascites, pleural effusions, skin changes, endocrinopathy, papilledema, and polycythemia/thrombocytosis. The clinical manifestations are likely caused by elevated VEGF, which markedly increases microvascular permeability. Most patients have solitary or multiple plasmacytomas. Bone marrow evaluation often shows plasma cell clonality, and therapy is directed at the underlying plasma cell dyscrasia. Hepatomegaly and ascites may falsely suggest underlying chronic liver disease. 212 Hematologic malignancies. The liver, as part of the reticuloendothelial system, is frequently involved in disseminated lymphoproliferative disease and usually signifies an advanced stage. 213 Hematologic malignancies are frequently associated with elevated liver chemistry tests but typically do not cause clinically significant hepatic dysfunction. The frequency of liver involvement varies widely depending upon the type of malignancy. Alternatively, some hepatic abnormalities may be due to drug toxicity, infections, amyloidosis, or extrahepatic obstruction from porta hepatis lymphadenopathy. Liver involvement in systemic lymphomas. The liver may be the site for a rare primary lymphoma or, more commonly, for spread from systemic lymphomas. There is an association of lymphoma with HIV, HCV, or EBV, post-transplant, infection, common variable immunodeficiency, rheumatologic disorders, celiac disease, IBD, thiopurine therapy, and possibly TNF inhibitor therapy. HBV-infected patients also have a 2 to 3-fold increased risk of developing non-Hodgkin lymphoma, NHL, although a cause-effect relationship has not been proven. 214 Almost 90% of hepatic lymphomas are NHL, with most being of B-cell origin. 213,215 NHL more commonly has malignant involvement of the liver than does Hodgkin lymphoma, HL. Imaging is often normal or shows multiple or diffusely infiltrating lesions. The less common focal liver lesions are usually hypoechoic on ultrasonography and hypoattenuating on CT scan. 216,217 Splenic involvement and lymphadenopathy support the diagnosis of lymphoma. Nonspecific histologic findings in both NHL and HL are portal lymphocytic infiltrates, hemosiderosis, steatosis, and granulomas, usually non-caseating, the last more common in HL than in NHL. 213,215,218 Immunotyping can characterize the phenotype of these cells. Many patients have no clinical or biochemical suggestion of hepatic involvement. Hepatomegaly or abnormal liver chemistry tests, such as a moderately elevated serum alkaline phosphatase level, do not correlate well with lymphoma 2 involvement. 219 Rarely, massive hepatic infiltration by tumor can result in acute liver failure, with an average survival of 10 days. 220 In NHL, diffuse large B-cell lymphoma is the most common subtype. This presents predominantly with tumor nodules distributed diffusely throughout the liver with a dense lymphoma 2 infiltrate. 213,215 T-cell-rich B-cell lymphoma, in contrast, is characterized by a scattered portal tract infiltrate with few neoplastic cells, often misdiagnosed as a reactive inflammatory condition or as T-cell lymphoma infiltration of the liver. The less common T-cell lymphoma lacks a typical infiltration pattern and may be confused with a drug-induced or viral hepatitis when biopsies just show increased numbers of T cells. A distinction between these possibilities would necessitate clonality analysis by T-cell receptor or immunoglobulin-heavy locus PCR. In HL, hepatic involvement is virtually always associated with splenic involvement, but the converse is not always true. Liver disease is usually diffuse with miliary lesions more often than masses. A predominantly portal infiltration is the most common histologic feature, with Reed-Sternberg cells detected only occasionally. 213,215 cholestasis is most commonly due to intrahepatic tumor infiltration, but extrahepatic bile duct obstruction by enlarged lymph nodes should be kept in mind. Rare conditions include idiopathic cholestasis and vanishing bile duct syndrome. 221 The degree of cholestasis is often disproportionate to the apparent tumor load and may respond to chemotherapy or lead to fatal liver damage. GI and liver involvement in leukemia. Leukemias can involve any part of the GI tract, with about 10% of patients being symptomatic. 222 GI involvement usually occurs during relapse due to leukemic infiltration of the bowel wall, immunodeficiency, coagulation disorders, or chemotherapy. Treatment reduces proliferation of normal cells, causes myelosuppression, and weakens areas of the bowel wall as it destroys the underlying malignancy. Although most patients are asymptomatic, others may complain of abdominal pain, bleeding, or diarrhea. Common oral problems include xerostomia, gingival bleeding, mucositis, infections, particularly Candidal, and dental disease. 223 The esophagus may have leukemic infiltrates, infectious esophagitis, most commonly candidiasis, HSV, or CMV, hemorrhagic lesions, e.g., petechiae, ecchymosis, erosions, ulcers, or chemotherapy-induced mucositis. 222,224 Leukemic infiltration of the bowel may present as ulcerations or as nodular lesions resulting in intussusception, obstruction, or a picture resembling cancer. 222,225,226 It can extend through the bowel wall, resulting in perforation. Less common are PLG and malabsorption. Leukemic infiltrates are found particularly in the terminal ileum and appendix, owing to the abundant lymphoid tissue in these areas. The picture may mimic IBD or be associated with pneumatosis cystoides intestinalis or pneumoperitoneum. 222,227 Immunodeficiency may lead to granulocytic ulcers with bacterial invasion and bleeding. Coagulation defects can produce intramural hematomas and hemorrhagic necrosis of the bowel. Painful anorectal lesions include thrombosed hemorrhoids, stercoral and neutropenic ulcers, fistulas, and abscesses. Neutropenic enterocolitis or typhlitis, from the Greek word typhlon, meaning cecum, is a necrotizing process involving the terminal ileum, cecum, and ascending colon. 222,227-230 It usually occurs during the onset or relapse of acute myelogenous leukemia, often following chemotherapy, and is a common source of fever. Other conditions associated with neutropenia may also be complicated by neutropenic enterocolitis. Distension of the cecum, sometimes associated with hypotension, impairs perfusion, leading to mucosal breaches and entry of organisms that proliferate profusely with the neutropenia. 222,231 Patients present with fever, right lower quadrant abdominal pain, diarrhea, bleeding, nausea and vomiting, dehydration and sepsis, and occasionally an acute abdomen. With sepsis, gram-negative bacteria are the most frequently identified pathogens. Bowel wall thickness of greater than 10 mm is seen on CT and Chapter 37. Gastrointestinal and hepatic manifestations of systemic diseases 543-37 ultrasonography and is associated with 60% mortality. 229,232 Most patients can be managed with intravenous fluids, transfusion of blood and platelets, granulocyte colony stimulating factor, and broad-spectrum antibiotics, with surgery reserved for complications. Infiltration of liver, spleen, and lymph nodes is common in leukemia, but the possible hemorrhagic complications resulting from liver biopsy make it difficult to discern the relative contributions of leukemic infiltrates, extramedullary hematopoiesis, IMH, and other infectious and toxic complications of these diseases. Although often asymptomatic, acute liver failure may develop. 233 Rarely, the pancreas, gallbladder, or bile ducts, cholangiopathy, may be involved. 234-236 Splenic rupture in acute leukemia, mainly with splenomegaly, may be due to leukemic infiltration, splenic infarction, or defects in coagulation, particularly thrombocytopenia. 237 A diffuse non-destructive infiltration of the liver is usually asymptomatic and without significant laboratory abnormalities. In chronic lymphocytic leukemia, the leukemic infiltrate involves the portal areas, usually leaving the limiting plate intact, although in some cases it may cause hepatocellular necrosis, bridging necrosis, and occasionally pseudolobule formation. 215 In other leukemias, sinusoidal involvement may be seen with or without portal infiltrates. Systemic mastocytosis. Systemic mastocytosis is characterized by multiple dense infiltrates of mast cells, MCS, in bone marrow or extracutaneous organs, mutations in the c-KIT gene, CD117, and elevated serum tryptase concentrations. 238-239 The classical skin finding of urticaria pigmentosa is seen with or without systemic involvement. The frequency of GI involvement is highly variable but probably second only to pruritus as a cause of morbidity. 240 Symptoms are thought to be due mainly to mediator release, e.g., histamine, leukotrienes, heparin, proteases, and less commonly to MC infiltration of the gut. Symptoms may include abdominal pain, diarrhea, and nausea/vomiting, often exacerbated by precipitants such as drugs, stress, and certain foods. Pain may be either dyspeptic or lower abdominal cramping. Occasionally the esophagus is affected with heartburn/esophagitis or motor disorders. 241 PUD may be underdiagnosed and can be caused by histamine-mediated gastric acid hypersecretion. Diarrhea also may be related to gastric hypersecretion, as well as to intestinal malabsorption, overproduction of prostaglandin D2, or occasionally to altered intestinal transit. 238-240-242 Endoscopic features are nonspecific: nodularity, erythema, ulcerations, urticaria-like lesions, thickened folds, purple pigmented lesions. 240 Histology may be diagnostic or nonspecific, with a mixed infiltrate that may include MCS, although MCS are commonly seen in other disorders, Fig 37.5. However, unlike other inflammatory diseases, the histology in systemic mastocytosis may include high numbers of MCS, MCS in aggregates or confluent sheets, abnormal MC morphology, and positive staining for CD25.243-244. Often, infiltrates contain plasma cells and eosinophils, but the presence of numerous MCS would be atypical for eosinophilic gastroenteritis. There may be expansion and distortion of crypt architecture as in IBD. 245 Crypt abscesses, however, are unusual. Also, although villus atrophy is found, the crypt hyperplasia typical of celiac sprue is usually not seen. Hepatomegaly and abnormal liver chemistry tests are common. The liver chemistry tests may be either a mixed pattern or an isolated alkaline phosphatase elevation, often from bone. 239 Liver biopsies may show portal MC infiltrates, eosinophilic infiltrates, extramedullary hematopoiesis, IMH, portal fibrosis, and sometimes cirrhosis. Portal hypertension may develop, although splenomegaly may also be due to MC infiltration. Liver stiffness by transient elastography may be seen. 246 Treatment is aimed at limiting MC degranulation and controlling pathologic MC tissue infiltration. 238 GI symptoms may improve with H1N/or NH2 receptor antagonists, oral disodium chromoglycate, or glucocorticoids. For aggressive disease with organ dysfunction, cytoreductive therapy with interferon or cladribine has shown limited response rates and duration. The KIT D816V, ASP-Val, mutation is present in 90% of patients with systemic mastocytosis, and an uncontrolled, Observational multinational study of 116 such patients reported that a multiple kinase inhibitor, midostaurin, is effective both in advanced mastocytosis and its highly lethal variant, MC leukemia. Imatinib, Gleevec, is currently FDA approved for patients with this D816V mutation. 247 The prognosis is good for the indolent or smoldering type, the latter with organ infiltration without organ dysfunction, but poor for the aggressive type, organ infiltration with dysfunction, or transformation to MC leukemia. Unlike systemic mastocytosis, the MC activation syndrome does not occur due to an increased MC number but rather a hyper-responsiveness of MCS that leads to an inflammatory mediator-driven multisystemic disorder. Mast cell activation syndrome may be associated with common variable immunodeficiency, postural orthostatic tachycardia syndrome, Lyme disease, and EDS, but may also be idiopathic. Symptoms typically are dermatologic AB Fig 37.5 systemic mastocytosis involving the colon. A. An interstitial infiltrate of mast cells with pale cytoplasm is present. HNE times 100. B. A mast cell tryptase immunohistochemical stain highlights the interstitial infiltrate, times 400. The patient also had bone marrow involvement. Courtesy Shehabai, MD, Dallas, TX. 544 Part 4 Topics involving multiple organs, hives, flushing, and burning, cardiovascular, dizziness and pre-syncope/syncope, GI, diarrhea, abdominal cramping, nausea/vomiting, and dysphagia, neurologic, brain fog, altered memory and headache, respiratory, dyspnea, wheezing, and nasal congestion, and constitutional, fatigue/malaise. Laboratory clues may include baseline elevation of serum tryptase, elevated 24-hour urinary histamine, elevation of 24-hour urine prostaglandin D2 or its metabolite prostaglandin F2, or documentation of these markers being significantly elevated above baseline when symptomatic. Treatment includes H1 and H2 receptor antagonists, antileukotrienes, or MC stabilizers. 248,249 Myelophthisic and myeloproliferative disorders. IMH is a reactive process from bone marrow failure and/or infiltration or from chronic hemolytic anemias. 250,251 The most common extramedullary sites for blood formation include the liver and spleen. As a result, IMH commonly presents as hepatosplenomegaly from diffuse infiltration associated with vague abdominal symptoms. Liver chemistry tests may be abnormal, but clinically significant liver dysfunction rarely occurs. Histology shows clumps of erythroid and myeloid precursors along with megakaryocytes in the sinusoids, space of Dease, and portal tracts. The pleomorphism differentiates this from leukemic infiltration. The most common form is diffuse infiltration, but well-defined nodules or masses, usually multiple, may be seen. They are hypoechoic or inhomogeneous on ultrasonography and hypodense on unenhanced CT scan. MRI appearance varies depending upon the activity of the IMH and the degree of iron deposition. 252,253 IMH may rarely be found in the GI tract, causing bowel obstruction, abdominal pain, bleeding, or ascites. 254,255 Ascites could be due to implants of IMH in peritoneum, omentum, mesentery, or bowel wall. Myelofibrosis is characterized by clonal myeloproliferation with bone marrow fibrosis and IMH. Portal hypertension may be due to increased portal blood flow related to massive splenomegaly, increased intrahepatic resistance and sinusoidal narrowing from IMH, and/or a hypercoagulable state resulting in Budd-Chiari syndrome or portal vein thrombosis. 256,257 Splenectomy can improve the hyperdynamic circulation due to IMH but cannot reduce the increased portal pressure due to obstruction of the intrahepatic portal veins. Complications of splenectomy include thrombocytosis with thrombotic events, as well as hepatomegaly, sometimes massive, due to transfer of the IMH to the liver. Thrombotic complications have been associated with myelofibrosis, polycythemia vera, and essential thrombocytosis. 258 Splenic infarction can cause left upper quadrant abdominal pain. Up to 50% of patients with Budd-Chiari syndrome have an overt myeloproliferative syndrome. Langerhans cell histiocytosis, also called histiocytosis X, eosinophilic granuloma, Lederer-Siewe disease, and Hand-Schüller-Christian disease, is an uncommon disorder involving mainly infants and children. 259,260 Infiltration of the GI tract is rare, 1.6% to 2.6%, and usually associated with severe systemic disease, the characteristic rash, and a poor prognosis, with more than 50% dying within 18 months of diagnosis. Affected patients complain of vomiting, bleeding, diarrhea, constipation, and or perianal disease. Malabsorption, PLGE, and even bowel perforation may occur. The diverse endoscopic findings include nodules, ulcers, polyps, luminal narrowing, and colitis. Liver disease may be found in 18% to 20%, the incidence of hepatomegaly is variable. Pathologic evidence of Langerhans cell histiocytosis may be found in the skin, liver, and GI tract. Hepatobiliary abnormalities include portal triaditis, bile duct proliferation, fibrosis with histiocytic changes, cholestasis, sclerosing cholangitis, and cirrhosis. 261,262 Hemophagocytic lymphohistiocytosis, HLH, also known as hemophagocytic syndrome, is an uncommon hematologic disorder categorized as one of the cytokine storm syndromes. It is life-threatening with severe inflammation caused by uncontrolled natural killer cell activity of the innate immune system, leading to lymphocyte and macrophage hyperreactivity and resulting in massive overproduction of cytokines. Primary HLH is a heterogeneous autosomal recessive disorder with an increased frequency of parental consanguinity. Secondary HLH occurs after strong immunologic activation, as may occur with rheumatic diseases such as adult-onset Still disease, discussed earlier, with systemic infection, or in patients with immunodeficiency syndromes or underlying malignancy. Secondary HLH is also known as the macrophage activation syndrome. Resultant overwhelming T lymphocyte and macrophage activation leads to clinical and hematologic disturbances, which culminate in death if untreated. Clinical manifestations include fever, lymphadenopathy, hepatosplenomegaly, and rash, 60%. Laboratory studies typically show pancytopenia, low fibrinogen, hypoalbuminemia, elevated liver chemistry tests, sometimes with jaundice, and marked elevations of C-reactive protein, ESR, serum triglycerides, and ferritin. Hemophagocytosis can be identified in the bone marrow, lymph nodes, and spleen. An elevated CD25 is often noted. Therapy involves treating the underlying cause, when possible. Often concomitant therapy using high-dose glucocorticoids, etoposide, cyclosporin, methotrexate, or intravenous immunoglobulin may be required. 263 Erdheim-Chester disease or polyostotic sclerosing histiocytosis is a rare disease characterized by abnormal proliferation of non-Langerhans histiocytes due to a disturbance of the RAS/MARC intracellular signaling pathway. Onset is typically in middle age, manifesting as bone marrow infiltration and nearly universal long bone sclerosis by inflammatory infiltrates of lymphocytes and histiocytes. Extraskeletal involvement is infiltrative and GI manifestations are uncommon, but liver biopsy may include xanthogranulomatous infiltration. Retroperitoneal fibrosis may lead to chylosocites 264 and PLGE. Mortality rates are high and therapy may include high-dose glucocorticoids, vinca alkaloids, anthracyclines, cyclosporin, or interferon alpha. 265 Dysproteinemias. Multiple myeloma may affect the GI tract by direct invasion of a specific organ, mass effect, or production of a malignant effusion. 266 GI involvement from AL amyloidosis is described later. The most common sites of myeloma 2 involvement are the liver, spleen, and lymph nodes. Clinically significant liver or GI tract involvement is rare, usually occurs late in disease, and is associated with a poor prognosis. Hepatomegaly occurs in up to 58% of patients, often with splenomegaly. Diffuse involvement of the liver is most common, although nodular patterns have been found. 267 An elevated serum alkaline phosphatase level is seen with tumor infiltration. The stomach, intestine, pancreas, and peritoneum are sites of spread. Symptoms are due to direct invasion resulting in perforation or hemorrhage in the stomach or intestine, mass-like effects with gastric, intestinal, or biliary obstruction, and production of ascites. Ascites may be due to portal hypertension from amyloidosis, malignant infiltration of the liver, heart failure, malignant seeding of the peritoneal cavity, or infectious, e.g., tuberculosis, peritonitis. Multiple myeloma may be associated with IBD or present an IBD-like picture. 268 Primary extramedullary plasmacytomas without evidence of multiple myeloma account for 3% to 5% of all plasma cell dyscrasias. Gut involvement, although uncommon, is noted from the oral cavity to anus. Manifestations include dysphagia, hemorrhage, pseudo-obstruction, and polyposis. 269 Some gastric plasmacytomas improve with HP treatment, although these may in fact be mucosa-associated lymphoid tissue lymphomas with extreme plasmacytic differentiation. 270 Although usually treated surgically or by radiation, endoscopic resection should be kept in mind. 271 Chapter 37 Gastrointestinal and Hepatic Manifestations of Systemic Diseases 545 37 Waldenström macroglobulinemia is characterized by malignant proliferation of B lymphocytes producing IgM. Although hepatosplenomegaly and lymphadenopathy are common, luminal GI tract involvement is rare. GI disease may be due to 1. Deposition of immunoglobulin light chain fragments as amyloid protein, 2. Infiltration of the gut wall with lymphoplasmacytic cells producing monoclonal IgM, negative Congo red staining, or 3. Lymphatic dilatation and obstruction from high viscosity of the interstitial fluid. 272,273 IgM deposits, which may stain with periodic acid Schiff, may lead to blunted and distended villi and lymphangiectasia. Its interference with function may result in malabsorption, PLGE, or pseudo-obstruction. Portal hypertension may develop from infiltration of portal tracts with lymphoplasmacytoid cells and/or an increased splenic vein inflow secondary to splenomegaly. 274 Ascites is rare. Red blood cell dyscrasias. Sickle cell disease, SCD, is an autosomal recessive abnormality of the beta-globin chain of hemoglobin, HB. 275,276 The resulting HbS polymerizes when deoxygenated to form a gelatinous network that stiffens the erythrocyte membrane and increases viscosity. This results in microvascular occlusion, with ischemia and infarction of the organs and red blood cell destruction. Some 8% of African Americans are heterozygous for HbS trait, and 0.2% are homozygotes. Splenic involvement in the first 6 months of life, splenic congestion, and sickling lead to functional asplenia. 277 As hemorrhages and infarctions occur, the spleen becomes smaller and is eventually replaced by fibrous tissue, termed autosplenectomy, Fig. 37.6. It is usually infarcted within the first 18 to 36 months of life. Paralleling the disappearance of protective HbF, splenic atrophy results in increased susceptibility to infection with encapsulated bacteria and appearance of Howell-Jolly bodies in red blood cells. Radiologically, the spleen is small and often calcified. 277 Acute splenic infarction is more common in SCHBC or S thalassemia than in homozygous SCD, owing to the combination of splenomegaly with near-normal Hb levels and relatively high blood viscosity. 275 It may even occasionally occur with SC trait in non-hypoxic conditions. Splenic infarction presents with left upper quadrant pain, nausea, and vomiting, a friction rub over the splenic area, and leukocytosis. It may result in abscesses or pseudocysts. The spleen may occasionally rupture or be involved with IM or hemosiderosis. Acute splenic sequestration, or the sudden pooling of blood in the spleen, may cause rapid splenic enlargement and a drop in Hb. 278 Rarely, hypovolemic shock and death may occur within hours if not prevented by transfusions. In homozygous SCD, it occurs only in infants and children. Subsequent progressive fibrosis of the spleen impairs sequestration. In SC thalassemia, acute splenic sequestration can occur at any age and there is a high recurrence rate that can be prevented by splenectomy or chronic transfusions. Biliary tract involvement, cholelithiasis, occurring in about 70% of patients during their lifetime, consists of pigmented stones resulting from elevated bilirubin excretion due to chronic hemolysis. 279-281 Calcium bilirubinate gallstones are often radiopaque and thus seen on plain films. The incidence of cholecystolithiasis in SCD with cholelithiasis ranges from 18% to 30%, greater than that found in patients with cholesterol gallstones. Laparoscopic cholecystectomy in asymptomatic SCD patients is controversial. 282-283 Perioperative management includes monitoring changes in arterial oxygen tension and pH, hydration, possible perioperative blood transfusion, early ambulation, and sometimes continuous positive airway pressure postoperatively to avoid atelectasis and SCD-related postoperative complications. A search for cholecystolithiasis should be considered pre- or postoperatively, using MRCP or EUS. 284 Sickle cholangiopathy presents as cholestatic jaundice without cholecystolithiasis and may be due to ischemic bile duct injury. 285 Such patients need to be followed for the possibility of developing bile duct stones. Hepatic involvement. Acute sickle hepatic crisis, which affects about 10% of patients admitted for painful crisis, is due to stagnation of sickled cells in the hepatic sinusoids, with decreased hepatic blood flow. 275-279 Patients present with right upper quadrant pain, nausea, tender hepatomegaly, low-grade fever, leukocytosis, and elevated serum aminotransferase and conjugated bilirubin levels. The aminotransferases are usually 1 to 3 times normal but may reach levels greater than 1000 IU/L. Treatment is supportive. In some cases, exchange transfusions are used. Sequestration of blood, although seen most commonly in the lungs and spleen, can occasionally affect the liver. Obstruction of blood flow through the sinusoids by sickled erythrocytes leads to compression of the bile ducts. The pooling of blood leads to acute hepatic enlargement, a rapid drop in hematocrit, increase in reticulocyte count, and mild increase in liver enzymes. and AB Fig 37.6 Imaging studies in a patient with sickle cell disease and autosplenectomy. Unenhanced CT of the abdomen, A, shows increased density of the small spleen, arrow. On MRI, B, the spleen is also small and diffusely hypointense in all sequences, arrow, consistent with the finding of dense calcification on CT. The calcifications and small size make detection of the spleen difficult on US. From Ebert EC, Nag RM, Hags Peel KD. Gastrointestinal and hepatic complications of sickle cell disease. Clin Gastroenterol Hepatal 2010, 8:483-9. 546 Part 4 Topics involving multiple organs. Bilirubin. Reverse sequestration results in a decrease in hepatic size and increase in hematocrit, suggesting that not all sequestered cells are destroyed. Occasionally, this results in hypervolemia, heart failure, and intracerebral hemorrhage. Acute sickle intrahepatic cholestasis is a rare, potentially fatal complication caused by widespread sickling in the sinusoids and results in hypoxia and intracanalicular cholestasis. 286 It is thought to represent a severe form of hepatic crisis with severe hyperbilirubinemia, coagulopathy, and renal insufficiency/failure ultimately resulting in liver failure. Early treatment including exchange transfusion is essential. Acute hepatic failure rarely occurs, usually in the presence of underlying chronic liver disease. 287 It is characterized by jaundice, variable serum aminotransferase elevations, progressive coagulopathy, and encephalopathy. Liver transplantation is an option in these patients. Of patients admitted to a hospital with homozygous SCD or sickle thalassemia, there was a 39% prevalence of acute veno-occlusive involvement of the liver. It was not associated with the severity of the crisis, was either mixed cholestatic hepatocellular or cholestatic, and generally had a benign course. 288-289 Hepatic infarction, appearing as a peripheral hypodense wedge-shaped lesion on CT, is a relatively rare clinical event. Liver abscesses, with fever and pain, perhaps due to a secondarily infected hepatic infarct, may occur as a result of diminished removal of bacteria from the bloodstream from functional asplenism and reduced IgG antibodies to polysaccharide antigens. Focal nodular hyperplasia, perhaps due to obstructive portal venopathy, may also be seen. Cocaine hepatotoxicity may markedly worsen liver function, and its arterial vasoconstriction likely contributes to tissue hypoxia, vasoocclusion, and further sickling. 290 Occasionally, hepatic or portal vein obstruction may occur in SCD. Miscellaneous GI problems. Abdominal pain frequently accompanies vasoocclusive crisis and may be difficult to distinguish from acute abdominal disease. It tends to be diffuse and associated with pain elsewhere, such as in the limbs and chest. The pain of vasoocclusive crises is typically relieved with hydration and oxygen within 48 hours. The abdominal crisis is thought to be due to small infarcts of the mesentery and abdominal viscera causing severe pain, peritoneal irritation, and a generalized ileus. 275 Acute pancreatitis is not common despite the frequency of gallstones. It may be due to gallstones or to microvascular occlusion with ischemic injury. 291 Duodenal ulcers in SCD may not be associated with high gastric acid outputs, suggesting that they are instead due to reduced mucosal resistance, possibly from ischemia. Ischemic bowel due to intravascular sickling and the resulting microvascular occlusion occasionally occurs. 292 Diagnosis of GI involvement. The elevated serum bilirubin, mostly unconjugated, is from the increased load of red cell heme on an acutely damaged liver. There is some enhancement of bilirubin conjugation by bilirubin induction of uridine diphosphate glucuronil transferase, which is elevated in these patients. 293 The serum bilirubin correlates with LDH levels, suggesting that chronic hemolysis and ineffective erythropoiesis, rather than liver disease, are the sources of hyperbilirubinemia. Elevated serum AST may be partly due to erythrocyte AST and to muscle breakdown, so hepatocyte injury is better reflected by an increase in serum ALT levels. The serum alkaline phosphatase level is often elevated during pain crises, mainly due to bone rather than liver isoenzymes. Liver biopsy, although not usually performed during an acute sickle crisis, may show intrasinusoidal sickling, Kupffer cell enlargement and erythrophagocytosis, and hemosiderosis, with variable fibrosis. Shrunken hepatocytes or perivenular necrosis, features characteristically seen in ischemic livers, are generally not seen in SCD. 275-279 The safety of liver biopsies has been questioned, especially during acute sickling crisis. 294 Patients with complications from biopsies have chronic venous outflow obstruction, marked hepatic sequestration of erythrocytes, and sinusoidal dilatation. Hemosiderosis with multiple transfusions and hemolysis in SCD. Hemosiderosis develops, with iron first found in the sinusoids where erythrocytes are taken up by the Kupffer cells. 295 As iron accumulation increases, it is then found in the hepatocytes, increasing the risk of liver damage. In thalassemia, iron is found in both the sinusoids and hepatocytes. Patients with thalassemia tend to require more transfusions than patients with SCD and have increased intestinal uptake of iron from ineffective erythropoiesis and, therefore, more iron visceral loading. 296 On CT, the density of the liver and spleen increases with hemosiderosis. On MRI, the magnetic signal diminishes in the liver as the iron concentration increases. 297-298 MRI T2 techniques correlate with hepatic iron content and can be used to guide therapy. There is a lack of correlation, however, between liver and cardiac iron content, so both organs should be evaluated. Ferritin is a poor measure of iron overload, because it is an acute phase reactant. The available iron chelators are deferoxamine, given parenterally, and the oral agents, namely deferiprone and deferazirox. Coagulation disorders. Intramural hematomas due to trauma or bleeding diatheses most commonly involve the duodenum or jejunum, respectively. 299-300 The second and third portions of the duodenum are vulnerable to damage from trauma. They are fixed between the anterior abdominal wall and the vertebral column, so they may be either compressed or torn away from the more mobile areas. Spontaneous hematomas are most commonly due to over-anticoagulation or bleeding diatheses. Patients present with a range of symptoms. Complications include bowel obstruction and intussusception. Unenhanced CT findings include homogeneous and symmetric intramural thickening that is hyperdense in the first 10 days, evolving into a hypodense area. Rapid clinical remission usually occurs with conservative management unless involvement is extensive. A lesion persisting for more than 2 months suggests another etiology. In von Willebrand disease, which is the most common inherited bleeding disorder, GI bleeding commonly occurs associated with GI angioectasias or without visible lesions. Hade syndrome, the association of calcific aortic valve stenosis and GI bleeding, may be due to an acquired deficiency of von Willebrand factor as the multimers are reduced in size from the shear stress 0.301,302. This abnormality is corrected or improved with aortic valve replacement. A similar phenomenon occurs after left ventricular assist device placement and accounts for angioectasia-related GI bleeding in 30% to 40% of such patients. Hemophilia is commonly associated with mucosal GI bleeding, often in the upper GI tract, especially with the use of traditional NSAIDs. 0.303,304. Concomitant chronic liver disease related to factor-acquired HCV commonly is present and can exacerbate GI bleeding potential. Hemolytic uremic syndrome, HUS, consists of a triad of renal impairment, microangiopathic hemolytic anemia, and thrombocytopenia, see Chapter 110. Triggers of HUS from sporadic non-toxin-producing Escherichia coli include non-enteric infections, especially Streptococcus pneumoniae, malignancies, pregnancy, transplantation, anti-cancer molecules, immunosuppressive agents, and antiplatelet agents. 0.305 Shiga toxin-producing E. coli 0157H7 accounts for the majority of cases of HUS. Undercooked hamburger is the most common vector, with other foods, e.g., apple juice, lettuce, also implicated. 0.306 Other modes of transmission include the fecal-oral route, particularly child daycare centers, Chapter 37 Gastrointestinal and hepatic manifestations of systemic diseases 547-37 Water consumption, including swimming pools, and animal contact. Children are predominantly involved, mainly during summer and autumn. After an average incubation period of 3 days, patients develop abdominal cramps, vomiting, fever, and diarrhea that becomes hemorrhagic in 70% of cases. HUS develops in 3% to 7% of patients in sporadic cases and up to 30% in some outbreaks. Stool cultures may be negative because excretion of E. coli is intermittent and bacterial counts are low. CT shows colonic wall thickening, often with a target sign, and pericolonic stranding. 0.307 Rarely, pancreatitis, hemiperitoneum, colonic perforation, or stricture may occur. 0.308,309 The suggestion that antibiotic therapy of E. coli 0157H7 increases the risk of developing HUS has been challenged in a meta-analysis. 0.310 Antimotility agents are contraindicated because they may delay clearance of the pathogen and may even increase the risk of developing HUS. Thrombotic thrombocytopenic purpura consists of a microangiopathic hemolytic anemia and thrombocytopenia, with or without neurologic dysfunction and renal insufficiency. 0.311-313 Most patients have low activity of the protease ADAMS 13, which degrades large von Willebrand factor multimers, predisposing to a thrombotic microangiopathy and platelet consumption. With profound thrombocytopenia, bleeding may also occur. Unlike HUS, the peak age is in the 4th decade. About 70% of patients have GI symptoms, which may include luminal ischemia and GI bleeding. Plasma exchange allows 80% of patients with thrombotic thrombocytopenic purpura to survive an episode without permanent organ damage. Endocrine diseases diabetes mellitus. Whether GI symptoms are increased in patients with diabetes mellitus, DM, is controversial. 0.314 The populations studied are quite variable. Confounding by population obesity of control groups is increasingly problematic, and publication bias is likely present. Symptoms suggestive of autonomic dysfunction, e.g., postural dizziness, lack of sweating, impaired erection or ejaculation, difficulty with bladder emptying, xerostomia, gustatory sweating, should be identified. Acute variations in blood glucose can influence motor function and the perception of sensations. 0.315-317 Poor glycemic control delays gastric emptying, which, in turn, affects glycemic control. Metformin is a common cause of diarrhea and fecal incontinence. 318 Loss of interstitial caudal cells. 319 Imbalances in the numbers of excitatory and inhibitory enteric neurons. 320 Autonomic neuropathy, and impaired vagal and sympathetic innervations can alter GI motor function. Central processing may perceive GI events in an abnormal way. 321 And there may be a reduction in sensory neuropeptides, e.g., substance P, impaired smooth muscle contractility, or ischemia from microvascular disease. 316 Diabetes and cancer. DM is probably associated with an increased risk of certain GI malignancies, e.g., cancers of the pancreas, liver, colon, although the data are conflicting. 314, 322-324 The association may be due in part to shared risk factors such as aging, obesity, diet, and physical inactivity. Metformin may reduce the risk of cancer, whereas insulin may increase it. 324, 325 DM occurring with cancer increases mortality in general and in cancer-associated surgery. 326 Insulin resistance with secondary hyperinsulinemia lowers the concentration of insulin-like growth factor, IGF, binding proteins, leading to an increase in bioavailable IGF-1 concentrations. 323, 324, 327 which may stimulate cancer growth. There is a modest increase in pancreatic cancer among patients who have DM for more than 5 years. 328, 329 Conversely, pancreatic cancer causes DM, as evidenced by the development of new-onset DM and its improvement in some individuals with tumor resection. Chronic pancreatitis with pancreatic insufficiency increases the risk of both DM and pancreatic cancer, see later. Pancreatic adenocarcinoma should be considered in an older patient with new-onset, poorly controlled DM, especially with weight loss. Glucagonoma is much more rare but may present similarly, perhaps also with cheilitis, glossitis, and the characteristic annular, crusted, and bullous rash necrolytic migratory erythema, see Chapter 34. DM is a risk factor for HCC. 333-31 Confounding factors are that patients with cirrhosis, who are at increased risk of HCC, may be glucose intolerant, and 30% may develop overt DM, and that comorbid HBV, HCV, obesity, fatty liver disease, or alcohol may increase HCC risk. DM is also associated with an increased risk of colorectal cancer. 327-332 High circulating levels of insulin, C-peptide, or IGF-1 and chronic insulin use increase this risk. Poor glycemic control, as evidenced by a HbA1c 7.5%, is associated with a younger age at presentation, more advanced tumors, and poorer survival than diabetics with a low HbA1c or non-diabetics. 333 Esophageal involvement. Although esophageal dysmotility may occur in up to 50% of diabetic patients, the prevalence of symptoms is only 25%. 314 Defects include decreased lay pressure, delayed transit, multi-peaked or spontaneous contractions, and reduced amplitude of contractions. 334 Esophageal dysmotility has been correlated with peripheral motor neuropathy measured by nerve conduction velocity. The frequency of gastroesophageal reflux in DM varies considerably, with endoscopic esophagitis in up to 40% of patients. 335 Aggravated by obesity, reduced parotid gland secretion of bicarbonate, and hyperglycemia. Delayed esophageal transit does not necessarily correlate with gastric emptying, suggesting that the GI tract is not uniformly affected by DM and that reflux is not mainly a consequence of delayed gastric emptying. With odynophagia and/or dysphagia, oral and esophageal candidiasis should be considered. Diabetic predisposing factors include impaired immunity, esophageal stasis from dysmotility, and hyperglycemic impairment of neutrophil function and opsonization. Gastric involvement. Gastric emptying in DM is extremely variable and does not closely correlate with symptoms. Patients with type 1 DM have a 15% to 20% incidence of parietal cell antibodies, autoimmune atrophic gastritis, 5% to 10%, and pernicious anemia, 2.6% to 4%. 336 Autoimmune atrophic gastritis can lead to iron deficiency anemia. Due to hypochlorhydric iron malabsorption, there is an increased risk for type I gastric carcinoids and probably gastric cancer. Type 1 diabetics should be tested for parietal cell antibodies periodically. Those with such antibodies should have a complete blood count, fasting serum gastrin, and serum iron and vitamin B12 levels. Although the association between DM and PUD is controversial, there is some evidence that DM increases the risk of ulcer bleeding, perhaps secondary to diabetes-related microcirculatory changes that may impair mucosal integrity. 337 There appears to be no clear association between HP and DM when looking at prevalence of the infection, relationship to symptoms and gastric emptying, or eradication rate. 338 Small bowel involvement celiac disease is found in an average of 4% of patients with type 1 DM from the US and Western Europe, compared to a prevalence of about 0.5% in that population without DM. 339,340 Shared 548 Part 4 Topics involving multiple organs. HLA Class II genes and non-HLA loci suggest common autoimmune origins. 341 GI symptoms may be absent in celiac disease. Patients may present with non-GI disorders such as short stature, pubertal delay, fat-soluble vitamin deficiencies, anemia, osteoporosis, and/or reproductive disorders. Type 1 diabetics with celiac disease may have poor glycemic control, hypoglycemic episodes, and microvascular complications. 342 These patients have a propensity to develop other autoimmune disorders, such as pernicious anemia, Addison disease, and autoimmune thyroid diseases. Screening all type I diabetics for celiac disease is controversial. The small bowel transit time in DM is quite variable and does not necessarily correlate with transit times in the stomach or colon. Diarrhea is found in up to 22% of diabetic patients, but constipation is even more common. 314 Diarrhea is often episodic, painless, and sometimes nocturnal and must be differentiated from fecal incontinence. See later. Steatorrhea may occur in as many as 75% of diabetics with diarrhea. Metformin is the most common diabetic medication to cause diarrhea, even after years of treatment. 318,343 Etiologies of diarrhea related to DM include drugs, fast transit, autonomic neuropathy, celiac disease, SBBO, excess use of sugar-free sweeteners, pancreatic insufficiency, and hormones. Neuropathy may cause diarrhea by altering fluid and electrolyte transport and by altering motility. Rare hormone-producing tumors induce both DM and diarrhea, such as those secreting glucagon or somatostatin. Treatment of diarrhea should be geared toward the specific etiology or otherwise is symptomatic with loperamide. Clonidine stimulates alpha-2 adrenergic receptors but may worsen orthostatic hypotension. A patch form may be tried if the oral form is not tolerated. 314 Octreotide, or the long-acting octreotide analog lanreotide may help. 344,345 Also reported is the use of selective serotonin 5-HT3 receptor antagonists. 346 Diabetic radiculopathy of thoracic nerve roots may cause otherwise unexplained upper abdominal pain in patients with diabetic neuropathy. Pain may be associated with anorexia and weight loss, mimicking an intra-abdominal malignancy. Affected dermatomal sensory loss and muscle atrophy/weakness may be physical examination clues. Electromyography of the abdominal muscles may show denervation. 347 Colonic and anal involvement constipation occurs in over half of patients with long-standing DM and is partly due to an impaired gastrocolic reflex and delayed colonic transit. Occasionally, megacolon and, rarely, intestinal pseudoobstruction may result. DM can lead to ischemic colitis with capillary basement membrane thickening and luminal narrowing of submucosal arterioles in the colon. 348 Fecal incontinence may be associated with dysfunction of the IAS and/or reduced sensitivity of the rectum to distension. 314 Control of hyperglycemia and perhaps biofeedback may improve fecal incontinence. Pancreatic involvement. Exocrine pancreatic insufficiency is common in DM and associated with reduced pancreatic size and changes of chronic pancreatitis by MRI and MRCP. 349-351 Possible mechanisms by which DM causes pancreatic insufficiency include diabetic vascular changes in the pancreas and autonomic neuropathy with impaired enteropancreatic reflexes. In type 1 DM, the autoimmune process may damage both endocrine beta cells and adjacent exocrine cells, and low insulin levels reduce its trophic effects on acinar cells. Half of type I diabetics have demonstrable changes in the exocrine pancreas. Alternatively, pancreatic disease may result in DM, type 3 DM, a condition that is probably underdiagnosed. 352,353 etiologies include chronic pancreatitis, hemochromatosis, pancreatic cancer, discussed earlier, autoimmune pancreatitis, and a partial pancreatectomy. In hemochromatosis, iron usually accumulates in pancreatic acinar cells but may also affect islet cells. DM usually occurs before or concurrently with the diagnosis of autoimmune pancreatitis, and glucocorticoids have variable effects. 354 The effects of pancreatic resection depend upon the portion of pancreas removed. Because glucagon-producing cells are mainly in the tail, pancreatic polypeptide-secreting cells are located in the head, and insulin-secreting cells are more evenly distributed. Unlike type 1 and type 2 DM, pancreatic DM is characterized by a deficiency in nutrient-stimulated pancreatic polypeptide and glucagon release, with consequent predisposition to hypoglycemia and a reduced incidence of diabetic ketoacidosis, DKA. Hypoglycemia will be accentuated by alcohol use and/or loss of glycogen stores in the liver. The role of pancreatic enzyme replacement in glucose control is controversial. These patients can develop many of the same complications as other diabetics over the long term, but their low incidence of obesity and hyperlipidemia, presumably from maldigestion, reduces the risk of vascular complications. DM occurs in 50% of patients with cystic fibrosis by the age of 30 years. It increases mortality and worsens lung function. 355,356 Abnormal chloride channel function results in thick, viscous secretions causing obstructive damage to the pancreas, resulting in fibrosis, fatty infiltration, and severe pancreatic atrophy. There is loss of alpha, beta, and pancreatic polypeptide cells and development of insulin resistance. Hypoglycemia is a problem due to a blunted glucagon increase with stimuli, liver disease, and malnourishment, but patients are rarely ketosis prone. Insulin, rather than oral diabetic agents, is recommended when the patient displays poor growth, low weight, or unexpected decline in pulmonary function. A high-calorie, high-fat diet should be used to maintain nutrition. DM is associated with an increased incidence of acute pancreatitis, a risk that is reduced by taking anti-diabetic drugs. 357 Acute pancreatitis can complicate DKA in 11% of cases. Transient hypertriglyceridemia is thought to be a contributing factor. 358 Abdominal pain may be mild or absent. Acute pancreatitis may worsen volume depletion and hyperglycemia associated with DKA. DKA itself can be associated with abdominal pain and mild elevations of amylase and lipase without pancreatic inflammatory changes being identified. Gallbladder involvement. Fasting gallbladder volume by ultrasonography can be normal or increased in diabetics. 359 Possible causes of gallbladder dysfunction in DM include a defect in the cholinergic pathway, reduced alpha-adrenergic tone, deficiency of cholecystokinin receptors. 360 Arteriolar disease impairing muscle contraction, hyperglycemia, and hyperinsulinemia. Proving that DM is a risk factor for gallstones has been difficult because of associated clearly established risk factors for gallstones, particularly obesity, hypertriglyceridemia, advancing age, and hyperinsulinemia. 314 The natural history of cholelithiasis in DM and surgical risks are probably similar to that in non-diabetics when controlling for the associated cardiovascular and renal diseases. 361 Hyperglycemia, vascular disease, and impaired host defenses increase diabetics susceptibility to infection. Emphysema 2 cholecystitis is an uncommon condition usually associated with DM. It is probably due to ischemia of the gallbladder from vascular compromise, with proliferation of gas-forming organisms. Hepatic involvement. Abnormal liver chemistry tests are common in type 2 DM, especially serum ALT. 362 If within 3 times the upper limit of normal and no cause can be found, oral anti-diabetic or lipid-modifying. Chapter 37 Gastrointestinal and hepatic manifestations of systemic diseases. 549 37 Therapy can be started. these regimens often decrease serum malt levels as tighter blood glucose levels are achieved. Hepatotoxicity is rare with currently available anti-diabetic medications. Hepatitis or acute liver failure has been described with thiazolidinediones, and cholestasis with sulfonylureas. 363 Metformin has not been associated with hepatotoxicity. Fatty liver, common in DM, is a manifestation of insulin resistance, often found in conjunction with the metabolic syndrome. DM has been shown to increase the risk of acute hepatic failure independent of underlying liver disease. 364 Cross-sectional and longitudinal studies have shown that HCV-positive patients have an increased risk of type 2 DM, odds ratio of 1.6 to 2.1, compared to uninfected controls, those with HBV, or those with other liver diseases. 363, 365, 366 Similarly, HCV is a strong predictor of new-onset DM after liver transplantation. 367 Insulin resistance accelerates fibrogenesis and upregulation of TNF-alpha in HCV promotes insulin resistance. 368 HCV eradication improves insulin sensitivity and reduces the incidence of DM. Rarely, in poorly controlled diabetics, acute liver injury manifesting as RUQ pain, hepatomegaly, and marked elevations of serum aminotransferases can occur related to glycogenic hepatopathy. Differentiating this condition from hepatic steatosis can require liver biopsy to show extensive PA-positive glycogenation of hepatic nuclei. There is reversibility with glycemic control. Hepatogenous diabetes affects 30% to 60% of cirrhotic patients. 369, 370 It is characterized by insulin resistance in muscular, hepatic, and adipose tissues, as well as hyperinsulinemia and an impaired response of pancreatic islet cells. There is a reduced frequency of micro and macroangiopathic complications, perhaps due to lower body mass index, lipids, and blood pressure compared to type 2 DM. Also, they may die of liver disease before diabetic complications have time to develop. They are at risk for hypoglycemia due to minimal glycogen storage in the liver, impaired hepatic insulin extraction, high catabolic rate, and sometimes superimposed alcoholism. These patients should generally have no dietary restrictions, because they are often malnourished. Oral hypoglycemic drugs are metabolized by the liver, so may lead to hypoglycemia. Although biguanides may be helpful because they reduce insulin resistance, metformin is associated with a risk of lactic acidosis and is relatively contraindicated in cirrhotic patients who drink alcohol. 371 Alpha-glycosidase inhibitors and thiazolidinediones may be useful in non-alcoholic fatty liver disease. Acarbose may reduce ammonia levels in patients with hepatic encephalopathy. 372 Liver transplantation cures DM in 67% of cirrhotic diabetic patients. 373, 374 Thyroid disease hyperthyroidism. Clinical manifestations of hyperthyroidism range from apathetic thyrotoxicosis to thyroid storm, with fever, tachycardia, agitation, and delirium. GI symptoms include abdominal pain, vomiting, weight loss, and change in bowel habits. 375 Hyperthyroidism may be associated with other autoimmune diseases such as pernicious anemia, celiac disease, and ulcerative colitis. 375-378 Dysphagia is a rare manifestation that may be related to direct compression from a goiter or nodule, excess thyroid hormone causing a myopathy affecting the striated muscles of the pharynx and upper third of the esophagus, or increased esophageal contraction. Velocity. Gastric emptying has been shown to be normal, rapid, or delayed. 375 Low acid secretion and hypergastrinemia are found in some studies. Autoimmune thyroid disease is linked to atrophic body gastritis. 379 Up to 25% of patients have diarrhea. 380 Accelerated transit time and excess fecal fat excretion are common. Mechanisms of steatorrhea include dietary fat hyperphagia and accelerated transit. The diarrhea in hyperthyroidism may be due to associated ulcerative colitis or celiac disease. 375, 378 Diarrhea may decrease with propranolol, suggesting improvement of a relative adrenergic stimulatory state. Although mild abnormalities in serum aminotransferases or alkaline phosphatase commonly occur in hyperthyroidism due to the thyroid dysfunction itself, drug therapy, propylthiouracil, or concomitant overlapping autoimmune liver disease, AIH and PBC, clinically significant abnormalities in thyroid function are rare. Severe cholestatic hepatitis, jaundice, and/or acute hepatic failure are rare but may occur due to a mismatch between increased hepatic oxygen consumption and hepatic blood flow. Predominant zone 3 hepatic necrosis with or without concomitant right-sided heart failure is typical. Responses to pharmacologic therapy of thyrotoxicosis may occur, but emergent thyroidectomy and/or hepatic transplantation may be required. Hypothyroidism is most commonly due to Hashimoto thyroiditis or to thyroid ablation for hyperthyroidism. The former is an autoimmune disease that is sometimes associated with other autoimmune processes such as ulcerative colitis, pernicious anemia, DM, celiac disease, and PBC. 375,378 The most common GI complaints in hypothyroidism are constipation, anorexia, nausea/vomiting, and abdominal pain. Esophageal manifestations of dysphagia and reflux may be due to a motility disorder with low lay pressure and reduced amplitude of contractions. 375 Patients may have reduced acid secretion or delayed gastric emptying, the etiology of which is unclear. Phytobezoars may be found in the stomach or intestine, occasionally resulting in obstruction. Hypothyroidism is associated with SBBO, causing abdominal discomfort, flatulence, and bloating. These symptoms often respond to antibiotics. 381 Small bowel transit time may be normal or delayed. 377 Colonic hypomotility may result in obstipation, ileus, megacolon, or volvulus. Megacolon and pseudovolvulus are rare, usually associated with severe hypothyroidism or myxedema coma, and may respond to intravenous thyroid hormone. 382 There may be transverse thickening of colonic haustrations or distended loops of bowel with air fluid levels that must be differentiated from intestinal obstruction. Surgery in these patients may be complicated by prolonged ileus. 383 Pathology may suggest a neuropathy or alternatively accumulation of glycosaminoglycans in the interstitial tissues. 375 Ascites in myxedema is characterized by high protein concentration, greater than 2.5 g/dl, with a variable serum ascites albumin gradient, and a low white blood cell count with a predominance of lymphocytes. 384 Resolution occurs with thyroid replacement, not with diuretics. Medullary carcinoma of the thyroid. Medullary carcinoma of the thyroid is a calcitonin-producing tumor of the C cells of the thyroid gland. It may be associated with Men's syndrome type 2. Diarrhea is seen in 1/3 of patients, particularly in those with extensive metastatic disease. 375 Its mechanism varies, being attributed to calcitonin, prostaglandins, 6-hydroxyindoleacetic acid, or non-hormonal causes. Parathyroid disease. Hyperparathyroidism with the advent of multi-channel biochemical screening that includes serum calcium measurements. Severe hyperparathyroidism is now unusual and milder cases predominate. GI complaints include constipation from large bowel atony, nausea/vomiting from gastric atony, anorexia, and weight loss. 385,386 Abdominal 550 Part 4 Topics involving multiple organs. Pain could be due to PUD or pancreatitis or related to atony. Whether the incidence of PUD increases in hyperparathyroidism is controversial. Gastric acid hypersecretion and/or hypergastrinemia have been found in some but not other studies. Constipation may be due to a reduction in neuromuscular excitability by high calcium levels. The incidence of acute pancreatitis in hyperparathyroidism ranges from 1% to 12%. Pancreatic calculi, mainly intraductal, have been noted in 80% of patients with pancreatitis and hyperparathyroidism. 385 In addition, calcium can promote conversion of trypsinogen to trypsin, resulting in damage to acinar cells. In converse, acute, often severe, pancreatitis can lead to hypocalcemia from a relative deficiency of parathyroid hormone secretion, as shown by correction of the calcium level with administration of parathyroid hormone. In addition, the hypocalcemia may be due to resistance to parathyroid hormone action in bones and kidneys resulting from fluid sequestration and reduction in effective arterial blood volume. Rarely there are genetic factors such as mutations in serine protease inhibitor Cazal type 1 and CFTR in hyperparathyroidism and pancreatitis. 387 Once a diagnosis of hyperparathyroid-induced acute pancreatitis is established, a parathyroidectomy should be performed. Acute pancreatitis may follow parathyroid surgery, perhaps because of acute rises in calcium with manipulation of the parathyroid glands or to a blunted response of calcitonin-producing cells from fatigue. 385 Hyperparathyroidism may also be associated with chronic pancreatitis. Hypoparathyroidism. The main GI manifestation of hypoparathyroidism is steatorrhea. It may be due to insufficient endogenous cholecystokinin release by duodenal mucosa following a meal, thereby reducing gallbladder contraction and pancreatic enzyme secretion. 388 Replacement of dietary long-chain triglycerides with medium-chain triglycerides reduces fecal fat losses, thus reducing fecal calcium losses from saponification. Hypoparathyroidism may occasionally be associated with celiac disease, with the malabsorption responding to a gluten-free diet. 389 Underlying celiac disease should be suspected even in the absence of diarrhea in a hypoparathyroid patient whose serum calcium levels do not respond to treatment. Hypoparathyroidism may cause a low serum alkaline phosphatase, but zinc deficiency, magnesium deficiency, malnutrition, Wilson disease, and hypophosphatasia deserve consideration in the evaluation. Adrenal disease. Over half the patients with adrenal insufficiency, Addison disease, have GI symptoms, such as nausea, vomiting, diarrhea, and abdominal pain. 390 Associated celiac disease is described in 8% to 12% of patients, with both diseases having similar HLA associations. 391 Poor absorption of glucocorticoids due to associated celiac disease may complicate the therapy of Addison disease, whereas glucocorticoid treatment may mitigate celiac sprue. Atrophic gastritis and pernicious anemia may also be present. 392 Elevated serum aminotransferases may occur in Addison disease and resolve on glucocorticoid replacement therapy. 393 Pheochromocytoma, a rare catecholamine-secreting tumor, presents with hypertension, palpitations, headaches, and diaphoresis. GI manifestations include nausea, vomiting, abdominal pain and, less commonly, constipation, ileus, megacolon, ischemic colitis, and perforation. 394,395 Catecholamines decrease intestinal motility and tone by relaxation of intestinal smooth muscle and cause ischemia from vasoconstriction of splanchnic arterioles. The effects can be relieved by alpha-adrenergic blockers such as phentolamine. Hypertensive emergencies can occur with the use of opioids and other medications, as during endoscopic procedures. Pituitary disease. The hypothalamic pituitary adrenal axis provides an important link between the brain and the gut. 396,397 Pituitary disorders infrequently affect the GI tract, except in association with MENI syndrome. Hypercortisolism, caused by the inappropriate secretion of corticotropin in Cushing disease, may be associated with an increased incidence of gastric ulceration when concomitant NSAIDs are used. Acromegaly, a rare disorder characterized by hypersecretion of growth hormone, is associated with increased length and circumference of the colon and slow colon transit time, so that the standard bowel preparation is often inadequate. 398 Acromegalic patients may have an increased risk of colorectal cancer, colonic polyps, and other GI tract cancers. 399 Increased growth hormone and IGF-1, which promote epithelial cell proliferation, are thought to play a role. Whether colonoscopic colorectal cancer screening should begin before age 50 in acromegaly is controversial. Octreotide treatment in acromegalics increases gallstone formation, probably owing to suppression of cholecystokinin release and gallbladder emptying. 400 Symptomatic gallstone disease may occur following withdrawal of octreotide. 401 Disorders of lipid metabolism. Hypertriglyceridemia to levels above 1000 mg/dl can cause acute and recurrent pancreatitis but rarely chronic pancreatitis. 402 Usually the patient has a familial hyperlipoproteinemia along with a secondary factor, such as poorly controlled DM, alcohol intake, or use of certain medications such as estrogen. The serum amylase level may be normal or minimally elevated as hypertriglyceridemia interferes with the amylase measurement. Familial hyperlipoproteinemia, particularly type 4, has a high incidence of gallstones. 403 Hypobetalipoproteinemia can be acquired secondary to malnutrition or severe liver disease. 404 Primary causes include abetalipoproteinemia, chylomicron retention disease, and familial hypobetalipoproteinemia. 405 Abetalipoproteinemia is a rare autosomal recessive disorder with fat malabsorption and elevated serum aminotransferases associated with hepatomegaly due to lipid-laden hepatocytes, occasionally progressing to cirrhosis. Lipid droplets are found in enterocytes, seen particularly with electron microscopy, owing to their lack of transport to the Golgi apparatus. 406 Patients with familial hypobetalipoproteinemia are usually heterozygotes who are asymptomatic, with or without fatty liver disease. Fabry disease, an X-linked deficiency of alpha-galactosidase A, is associated with GI symptoms, mainly abdominal pain and diarrhea, in 50% to 60% of patients. 407-409 It may be confused with diarrhea-predominant irritable bowel syndrome. Gastroparesis, vomiting, autonomic neuropathy, bowel dilatation, formation of diverticula, reduced peristalsis, and SBBO may be present. Symptoms may improve with enzyme replacement therapy using agalsidase alpha or beta. Gaucher disease, with deficiency of glucocerebrosidase, results in the accumulation of glucosylceramide within cells of monocyte/macrophage origin. 410-411 The characteristic Gaucher cells are macrophages engorged with lipid with a crumpled tissue paper appearance and displaced nuclei. Hepatosplenomegaly due to glycolipid-laden reticuloendothelial cells in the sinusoids is common. Hepatocytes are spared, so liver failure is uncommon. Portal hypertension, also uncommon, may be due to increased forward portal blood flow secondary to splenic enlargement and/or to intrahepatic obstruction from extensive deposits of Gaucher cells. The former abnormality is managed by splenectomy, and both are managed by enzyme replacement therapy. Splenectomy, however, may increase hepatic glycolipid deposition with loss of the spleen as a storage site. The incidence of gallstones, mainly composed of cholesterol, is increased, particularly after splenectomy. 411 Chapter 37 Gastrointestinal and Hepatic Manifestations of Systemic Diseases 551 37 Niemann-Pick disease type B, with deficiency of acid sphingomyelinase, is characterized by accumulation of sphingomyelin within lysosomes, mainly in monocytes/macrophages. 412 Early on, hepatic accumulation is isolated to Kupffer cells, but other cell types, particularly hepatocytes, are affected as the disease progresses. Portal hypertension, liver failure, and cirrhosis are uncommon. Tangier disease is an autosomal recessive disorder characterized by accumulation of cholesterol esters in macrophages in tonsils, thymus, lymph nodes, marrow, liver, and the gut. Tangier disease is caused by a mutation in the adenosine triphosphate binding cassette protein, ABCA1, which mediates the efflux of excess cellular sterol to apolipoprotein AI, a step leading to the formation of HDL. These patients have very low levels of plasma cholesterol and HDL, owing to a lack of apolipoprotein AI. The striking clinical findings include yellow-orange streaked tonsils in 80% of cases, hepatosplenomegaly, and peripheral neuropathy. Patients may have diarrhea without steatorrhea. Colonoscopy reveals orange-brown mucosal spots throughout the colon and rectum, and laparoscopy reveals similar yellow patches on the surface of the liver due to cholesterol esters in hepatic reticuloendothelial cells. Renal diseases anorexia, nausea, vomiting, abdominal pain, and constipation are common in renal failure. 413-415 Nausea has many causes, including the dialysis disequilibrium syndrome, uremic toxins, hypotension, and rapid changes in osmolality. Gastroesophageal reflux also occurs, particularly in those undergoing peritoneal dialysis. Minimizing exchange volumes, especially at night, may help. 416 Gastric emptying studies have yielded conflicting results and do not correlate with symptoms. Gastric dysfunction may be associated with impaired gastric myoelectric activity. 417 Increased levels of GI hormones, e.g., cholecystokinin, gastrin, that modulate GI motility. 414 uremic toxins, DM, autonomic nerve dysfunction, and the physical restriction caused by PD. Gastroduodenal lesions, usually inflammation, erythema, and erosions, are common in patients with renal failure but do not correlate with symptoms. 418 Whether gastric acid or serum gastrin is altered is controversial. The prevalence of HP infection is usually normal or reduced in patients with renal failure. 419 Occult and overt GI bleeding are common in renal failure. For those admitted for upper GI bleeding, the mortality and rebleeding rates are greater than for those bleeding patients without renal failure. 420,421 GI bleeding is probably aggravated by the effects of uremia on the GI mucosa, platelet dysfunction, and antiplatelet agents, NSAIDs, and / or heparinization during hemodialysis. The prevalence of angioectasias in the upper or lower GI tract may be increased in patients with renal failure and may be discovered by investigation of GI bleeding. 422 These vascular lesions tend to bleed more often in patients with renal failure than in the general population. Acute mesenteric ischemia is generally non-occlusive and may be due to episodes of hemodynamic instability during hemodialysis. 423-425 It tends to involve the right side of the colon or multiple areas and has a poor prognosis. Risk factors include NSAID use and aggressive erythropoietin administration. Constipation and fecal impaction are significant problems for patients on hemodialysis, and to a lesser extent those on peritoneal dialysis. Causes include inactivity, dehydration, reduced fiber intake, due to potassium-restricted diets, metabolic abnormalities, phosphate binders, aluminum antacids, ion exchange resins, comorbidities, and prolonged colonic transit time. 413 415,426,427 Diarrhea due to SBBO from small bowel dysmotility. 428 Abnormal bile acid metabolism, exocrine pancreatic insufficiency, or amyloidosis, the last two discussed later, may also occur. Oral sodium phosphate used as a bowel preparation may result in phosphate nephropathy, hyperphosphatemia, hypocalcemia, hypokalemia, and / or hyper or hyponatremia, although heterogeneity of the studies makes the risk unclear. 429-432 Magnesium-containing laxatives could result in hypermagnesemia. GI necrosis may occur with sodium polystyrene sulfonate, K-oxalate, commonly used to treat hyperkalemia, in combination with sorbitol to prevent constipation. Cleansing enemas may decrease the risk. Aluminum-containing antacids or sucralfate could lead to aluminum toxicity or fecal concretions, causing obstruction and / or perforation. Patients on hemodialysis may have an increased risk of perforation during colonoscopy. This is partly due to deposition of beta-2 microglobulin, suggesting that GI amyloidosis is involved. See later. 433 The mortality after emergency abdominal surgery is high for patients on hemodialysis. 434 Peritonitis related to the dialysis catheter in patients on peritoneal dialysis is most commonly caused by a single organism and usually resolves with appropriate antibiotics. However, a non-resolving peritonitis, polymicrobial pathogens, and an increase in effluent amylase concentration suggest bowel perforation. 435 Diagnosis of perforation may be delayed, and hence mortality increased, because patients are given antibiotics for presumed peritonitis from peritoneal dialysis, partially treating the infection. Abdominal pain is diffuse with reduced intensity, owing to lack of contact of parietal and visceral peritoneum. In addition, continuous peritoneal lavage dilutes the bacterial load, reducing abscess formation, so that CT may be unrevealing. To complicate the picture, pneumoperitoneum is seen in patients on peritoneal dialysis, especially with catheter-induced peritonitis, although the incidence is improving with better technique. 436 Sclerosing peritonitis, a rare and lethal condition in peritoneal dialysis, is characterized by peritoneal thickening that encapsulates the bowel, causing obstruction. 437-438 CT shows peritoneal thickening and calcification, loculated fluid collections, and adherent small bowel loops. Hernias are common in patients on peritoneal dialysis, especially at the catheter insertion site, inguinal canal, umbilicus, and sites of previous surgeries. Peritoneal dialysis fluid, under increased intra-abdominal pressure, can dissect through the peritoneal membrane into the soft tissues of the anterior abdominal wall, causing edema. Pancreatic parenchymal changes and exocrine insufficiency have been found in patients on peritoneal dialysis. 439, 440 high serum parathyroid hormone levels, hypertriglyceridemia, elevated pancreatic stimulating hormones, e.g., cholecystokinin, irritation of the pancreas, increased intra-abdominal pressure by the dialysate, and amyloidosis have been implicated. Whether the incidence of pancreatitis is increased in patients with renal failure or on hemodialysis is controversial. Although serum amylase levels are elevated from reduced clearance, a serum amylase, or lipase, above threefold normal and/or positive CT findings suggests pancreatitis. Neurologic diseases. Because of the importance of nerves and neurotransmitters on GI function, see Chapter 4, it is not surprising that a wide variety of neurologic diseases are frequently associated with GI symptoms. Diseases of the central nervous system. Abdominal migraine affects 1% to 4% of children, particularly girls, with an onset between ages 7 and 12 years. It is also occasionally seen in adults. 441,442 It is characterized by recurrent attacks of non-colicky, intense, acute periumbilical pain. The attacks last from 1 to 72 hours and are associated with anorexia, nausea, vomiting, and/or pallor. Headache is not a necessary feature. The intervening periods are pain-free. A family history of migraine is common. Non-pharmacologic therapy involves the 552 Part 4 topics involving multiple organs, removal of triggers, e.g., certain foods, stress, prolonged fasting, altered sleep patterns, travel. Anti-migraine therapies, e.g., propranolol, cyproheptadine, triptans, pizotifen, may be successful. Abdominal epilepsy is a rare condition, found more commonly in children than adults. It is characterized by 1. Paroxysmal GI complaints, usually abdominal pain, nausea, and vomiting of unclear etiology. 2. Symptoms of a CNS disturbance, usually lethargy and confusion. 3. An abnormal encephalogram indicating a seizure disorder. And 4. Sustained improvement with anticonvulsant medication. 443,444 The abdominal pain usually lasts for minutes and is sharp or colicky. The abdominal and CNS complaints in adults may be more diverse than in children. There is probably a spectrum, with GI symptoms associated with seizures, abdominal auras, or more subtle neurologic symptoms. The primary problem is often in the brain, usually in the temporal lobe, although it may arise from visceral stimuli with connections to the brain. Response to anticonvulsant therapy is not by itself a diagnostic criteria, because anti-epileptic drugs may improve abdominal pain via a sedating or placebo effect, and some cases of abdominal epilepsy are refractory to medication. Head trauma is associated with stress gastropathy and delayed gastric emptying. 445 Such patients often do not tolerate enteral feedings and develop vomiting, abdominal distension, increased gastric residual volumes, reflux, aspiration, and pneumonia. Gastric emptying delay is due to suppressed vagal nerve activity from increased intracranial pressure, elevated corticotropin releasing factor, hyperglycemia, medications, sedatives, opioids, and catecholamines, inflammation, electrolyte disturbances, and altered enteric flora. Enteral nutrition can be started even with a mild ileus, because it promotes gut integrity and motility. Treatment includes prokinetic therapies and perhaps an opioid receptor antagonist. 445,446 Cerebrovascular accidents may cause pharyngeal dysphagia, especially a brainstem lesion that involves the swallowing center. 447,448 Cerebrovascular accidents also result in stress gastropathy with ulcers and GI bleeding. Constipation is due to a prolonged colonic transit time, immobility, and altered diets. Multiple sclerosis, MS, is the most frequent chronic neurologic disease in young persons in developed countries. GI disturbance is present in around 40% of MS patients, particularly constipation and fecal incontinence. 449,450 also seen are early satiety, nausea and vomiting, and postprandial discomfort associated with delayed gastric emptying. There is an increased prevalence of celiac disease, and in their first-degree relatives, but not of DQ2 and DQ8 genetic markers. 451 Constipation may be associated with prolonged colonic transit time, pelvic floor dysfunction, reduced colonic compliance, immobility, paradoxical anal contractions, and an absence of postprandial colonic motor and myoelectric responses. Defecography may demonstrate pelvic outlet obstruction with failure of the puborectalis and anal sphincter muscles to relax. 452 Occasional patients develop intrarectal intussusception, reduced by perineal pressure. Medications commonly used in MS, e.g., muscle relaxants, anticholinergics, antidepressants, opiates, can also contribute to constipation, as will generalized muscle weakness, which impairs generation of intra-abdominal pressure. Fecal incontinence in MS may be due to reduced external anal sphincter tone, reduced anorectal sensation, and spontaneous rectal contractions. It should not be confused with overflow incontinence secondary to fecal overloading. Typical pharmacologic therapy is usually effective, but mechanical evacuation is sometimes required. Biofeedback may help, especially in mild disease. 453 Spinal cord injury. Patients with spinal cord injury, SI, most commonly have constipation, distension, abdominal pain, bowel accidents, and autonomic hyperreflexia. 454, 455 Spinal shock occurs for several weeks after the injury when all autonomic and reflex activities are lost below the level of cord transection. The abdomen is distended and flaccid, with no sensation below the level of injury and with absent or hypoactive bowel sounds due to gastric dilatation and a paralytic ileus. The incidence of ulcer disease and hemorrhage is increased. Acute abdominal pathology is difficult to diagnose during this period. When spinal shock ends, there is a return and then exaggeration of autonomic reflex activity below the level of injury. Autonomic hyperreflexia is a potentially dangerous intense reflex vasoconstriction in patients whose psi lies above T6 or the greater splanchnic outflow. The result is hypertension, diaphoresis, bladder spasms, and diarrhea. It can be precipitated by rectosigmoid distension and anal manipulation and can be reduced by anesthetic suppositories. 456 The diagnosis of an acute abdomen may be delayed in a high-level psi, raising the mortality rate, because rigidity and rebound tenderness may be absent. 457 Those with appendicitis have a perforated appendix in over 90% of cases. 454 Early clues include autonomic hyperreflexia, referred shoulder pain, dull and poorly localized abdominal pain, distension, increased spasticity, nausea, and vomiting. Abdominal operations are challenged by deformities or spasticity, making the procedures technically difficult. Retention sutures may be needed to close wounds due to tension from abdominal spasticity. Patients may have hyperreflexic hypertension, decreased pulmonary excursion, prolonged ileus, and chronic septic foci, increasing the risk of wound infections. Patients with psi are predisposed to gastroesophageal reflux from their supine position, increased intra-abdominal pressure due to constipation, and use of intra-abdominal muscles for transfers. 458 Because the posterior wall of the pharynx lies adjacent to the cervical vertebrae, cervical trauma may impinge upon or even perforate the pharynx. Defective UES relaxation in those with cervical psi reduces clearance of oral secretions and impairs swallowing. 459 This may be due to injury of the UES and/or its innervations and to interventions such as tracheostomy and anterior spinal surgery. Gastric emptying is either delayed or normal in psi patients. 454 Promodality agents can be effective because the enteric nervous system and smooth muscle layers are intact. Superior mesenteric artery syndrome, Wilkie's syndrome, cast syndrome, where the third portion of the duodenum is intermittently compressed by the overlying superior mesenteric artery, may occur following rapid weight loss, prolonged supine positioning, and the use of spinal orthoses. Constipation and fecal incontinence are common in patients with fecal impaction, megacolon, stercoral ulcers, and hemorrhoids may also result. 460,461 Delay in colon transit time is frequently found. The ability to increase intra-abdominal pressure is lost in lesions above T7, promoting constipation. The external anal sphincter is tight, such that stool is retained. When spinal reflexes are lost, there is more incontinence and less constipation. The external anal sphincter does not contract with increased intra-abdominal pressure or with rectal distension. Colon evacuation should be done after a meal to take advantage of the gastrocolic reflex. 462 A laxative may be introduced, followed by digital stimulation of the anus and rectum to dilate the anal canal and relax the puborectalis muscle. Other techniques used are abdominal massage, manual evacuation, transanal irrigation, and neostigmine with glycopyrrolate, an anticholinergic agent that reduces the side effects of neostigmine. 463,464 More aggressive modalities are anterior sacral root stimulators, sometimes combined with an S2 to S4 posterior sacral rhizotomy, antegrade continence enemas, and placement of a colostomy. 454,465 In the first 6 months after biliary sludge rather than gallstones are found. Afterwards, the prevalence of gallstones or cholecystectomy is high, 17% to 31% of patients. For unclear Chapter 37 Gastrointestinal and Hepatic Manifestations of Systemic Diseases 553 37 reasons. Although some patients have other risk factors for gallstones. 466 These patients are usually accurately diagnosed with acute cholecystitis, and morbidity and mortality from the cholecystectomy is acceptable. 467 Extrapyramidal movement disorders. Movement disorders arising from basal ganglia are classified as hypokinetic, Parkinson disease, and hyperkinetic, Huntington disease. Lewy bodies, the pathognomonic feature of Parkinson disease, are found in the enteric nervous system of the esophagus, stomach, and colon. 468 Dopaminergic deficiency in the enteric nervous system and involvement of the dorsal motor nucleus of the vagus, reducing parasympathetic innervation to much of the GI tract, may be pathogenic features. In Parkinson disease, saliva is excessive, not because of increased production but rather from reduced effectiveness of swallowing. 469 Sometimes resulting in drooling from a stooped posture and a tendency for the mouth to remain open. Local delivery of anticholinergic agents may be useful. All stages of swallowing, oral, pharyngeal, or esophageal, may be affected by Parkinson disease. There is a delay in triggering the swallowing reflex associated with impaired tongue movement and a prolonged pharyngeal stage. 470 The result is vallecular pooling, leading to aspiration, often asymptomatic, worsened by a decreased cough reflex, and contributing to pneumonia, a leading cause of death in Parkinson disease. Various esophageal abnormalities have been found in Parkinson disease, including a peristalsis and multiple simultaneous contractions. 471 Delayed gastric emptying, particularly of solids, with impaired gastric myoelectric activity. 472-474 is found in the majority of Parkinson disease patients, does not necessarily correlate with symptoms, and may be present early in disease. Nausea may be a medication side effect rather than due to delayed gastric emptying. Gastroparesis may interfere with levodopa absorption, whereby increased gastric dwell time allows for breakdown by gastric dopa decarboxylase to dopamine, which cannot be absorbed by the intestine. This effect may be ameliorated by giving levodopa between meals, using soluble levodopa, or alternative routes of administration, parenteral, nasal, sublingual, rectal, or jejunal. 475 Metoclopramide is contraindicated. It aggravates Parkinson disease by blocking central dopamine receptors. The dopaminergic D2 receptor antagonist domperidone can be used safely because it does not cross the blood-brain barrier, and 5-HT4 receptor agonists, e.g., mosapride not available in the US and tegaserod limited US availability, may improve gastric emptying, presumably by increasing acetylcholine release. Gastritis caused by HP may interfere with levodopa absorption, an improved response to levodopa occurs after its eradication. 476 SBBO is more prevalent in patients with Parkinson's disease than in controls, presumably from gut dysmotility, and is associated with bloating and flatulence. 477 Constipation is frequent and even found in patients who have not yet developed Parkinson. 478,479 It is aggravated by certain medications, reduced mobility, and weak abdominal straining pressure, from muscle rigidity and failure of coordinated glottis closure. Rarely, megacolon, pseudo-obstruction, volvulus, or even perforation may occur. Prolonged orocecal transit time is the main cause of constipation. 479 Muscles involved in defecation may not act in a coordinated fashion. Dystonia may prevent the anal sphincter from relaxing, resulting in an abnormally large post-defecation residual. Botulinum toxin injection of the puborectalis muscle and/or external anal sphincter may help. 480 But fecal incontinence could result. Apomorphine injections, an opiate/dopamine agonist, may ameliorate paradoxical anal sphincter contraction. Huntington disease is an autosomal dominant neurodegenerative disease characterized by involuntary movements, psychiatric disturbance, and cognitive decline. The dysphagia in Huntington disease occurs in the preparatory oral phase, postural instability, tachyphagia, poor lingual control, the oral phase, the pharyngeal phase. 481 or esophageal phase. 482 Gastritis or esophagitis are commonly found endoscopically in asymptomatic patients. 483 But gastric emptying is normal. 484 Diseases of the autonomic nervous system. Autonomic nervous system dysfunction is usually measured by cardiovascular abnormalities, heart rate variability to breathing or Valsalva maneuver or measurement of orthostatic blood pressure, but can also be assessed by quantitating sweat production or function of postganglionic sympathetic axons. Associated features may be orthostatic hypotension, dry eyes and mouth, cold hands and feet with color or trophic changes, changes in sweating, and dysfunction of the urinary bladder and sexual performance. 485,486 Autonomic dysfunction is often preceded by a viral syndrome. The spectrum ranges from painautonomic to selective adrenergic or cholinergic failure. GI symptoms, e.g., abdominal pain, bloating, nausea, vomiting, constipation, diarrhea, occur in up to 85% of patients. There may be associated hypomotility or uncoordinated contractile activity of the GI tract. The etiology may be immune-mediated, as suggested by a perivascular mononuclear cell infiltrate in the epineurium and the association with ganglionic acetylcholine receptor antibodies in some patients. Secondary causes of autonomic neuropathy include the porphyrias, infections with herpes viruses, rubella, DM, paraneoplastic autonomic neuropathy, amyloidosis, myasthenia gravis, Chagas disease, and botulism. Disease of the neuromuscular junction. Myasthenia gravis is a disorder of neuromuscular transmission causing fatigable muscle weakness. Dysphagia and aspiration are common and occasionally may be the sole manifestation of the disease. 487,488 The pharynx is usually involved, and esophageal abnormalities may occur. Classically, contractions weaken with repetitive swallows and may improve with edrophonium, tensilin test. Myasthenia gravis occasionally develops during interferon therapy and may be associated with other autoimmune diseases such as pernicious anemia, AIH, or PBC. 489,490 Muscular dystrophy. Duchenne muscular dystrophy, MD, is caused by a mutation of the dystrophin gene, which results in abnormal dystrophin, critical for muscle structure and function. 491 Dystrophin is found not only in skeletal muscle but also in smooth muscle cells and myenteric neurons, and thus GI symptoms may occur. Myotonic MD is characterized by progressive muscular weakness. Most of the GI tract can be involved, although the severity generally does not correlate with degree of skeletal muscle involvement. 492 The elevated serum aminotransferases in patients with MD may be confused with liver disease. Although the amount of AST in muscle is much greater than that of ALT, the values are about equal in the serum in MD, generally no more than about 600 IU/L, owing to greater clearance of AST. 493 Creatine phosphokinase is usually at least 20-fold higher than serum AST and ALT, indicating muscle rather than liver disease. Another distinction is the normal serum gamma-glutamyl transferase level in patients with MD.494 oropharyngeal symptoms are typical and may lead to aspiration. Pharyngeal contractions may be asymmetric or low amplitude, and UES pressure is low. 492. The esophagus may be dilated and the amplitude of esophageal contractions may be low with 554. Part 4 Topics involving multiple organs. Poor coordination. Some patients may have complete atony of the esophageal body. Lay pressure may be normal or reduced. Patients often have few to no symptoms despite esophageal dysmotility. Patients often have early satiety, nausea, and vomiting, epigastric pain, and or bezoars related to delayed gastric emptying and a reduced postprandial increase in motilin levels. 495 Response to metoclopramide suggests some preserved smooth muscle function and implies an underlying neuropathy in some patients. Episodic severe diarrhea, malabsorption, nonspecific abdominal pain, and fecal incontinence are common complaints. 492 Delayed small bowel transit may lead to SBBO, with 70% of patients responding to antibiotics. 496 Jejunal manometry is more sensitive than barium studies to detect motor abnormalities of the small bowel. Megacolon with risk of volvulus or perforation may be seen. Anorectal manometry shows low anal resting and squeeze pressures in some studies. Electromyography may show myopathic potentials with myotonia or decreased duration and amplitude of the motor units of the external anal sphincter. Pathology may show an atrophic, fibrotic EAS with skeletal muscle replaced by smooth muscle from the IAS. Pulmonary disease. Chronic obstructive pulmonary disease and its therapy is associated with gastroesophageal reflux. Chronic obstructive pulmonary disease predisposes to PUD and increases mortality associated with perforated or bleeding ulcers, especially with use of glucocorticoids. The contribution of smoking per SE to ulcer disease is discussed in Chapter 53. The GI manifestations of cystic fibrosis and alpha-1 antitrypsin deficiency are discussed in Chapters 57 and 77, respectively. Critical illness ICU patients are difficult to study because they are a heterogeneous and complex group. Frequent upper GI dysmotility. 497 manifests as high gastric residual volumes, abdominal distension, vomiting, regurgitation, and aspiration. 498,499 The resulting intolerance of enteral nutrition along with a predominance of catabolism over anabolism leads to malnutrition, which is associated with increased morbidity and mortality. Bacterial colonization of the upper airways may originate from flora in stagnant gastric contents and lead to pneumonia. 500 Whether acid-reducing therapy worsens this is unclear. Intolerance to feeding is associated with changes in gut flora and organic acids. Such patients have a higher incidence of bacteremia and mortality than those without feeding intolerance. 501 Lay pressure is low to absent, and esophageal body contractions are infrequent and of low amplitude in ventilated and sedated patients. 498 Salivary secretion is diminished and straining frequent, usually coughing from endotracheal tube suctioning, all contributing to reflux and aspiration. Acute stress-induced gastropathy is common, with hemorrhage increased in patients on mechanical ventilation and those with significant coagulopathies. ILEUS 502 is discussed in more detail in Chapter 124. Constipation, with no bowel movement in the first 96 hours in the ICU, occurs in 50% of patients. 503 The main risk factors are opioid intake and disease severity. Routine administration of stimulant or osmotic laxatives should be considered. Fiber laxatives should be used with caution because they may result in fecal impaction if fluid intake is inadequate. Ischemic colitis may be seen following hypotensive episodes. Acalculous cholecystitis is also commonly seen in severely ill ICU patients and manifests as acute abdominal pain, unexplained leukocytosis, or abdominal sepsis. Sepsis. Hepatic involvement in sepsis is the most common cause of jaundice in ICU patients. The liver can be involved in sepsis in two phases. In the first, hepatic hypoperfusion occurs initially with septic shock, leading to poor synthetic function of the liver and elevated serum aminotransferases. In phase 2, hepatic dysfunction is caused by the liver's response to sepsis as the major protective organ. Hepatic Kupffer cells detoxify bacterial endotoxin and remove bacteria from the circulation. 504-506 Their activation causes recruitment of neutrophils, which, in turn, injure hepatocytes. Hepatic endothelial cells acquire procoagulant and pro-inflammatory activities. 507 Endothelial damage, decreased blood flow through the sinusoids, and formation of fibrin microthrombi are the result of endotoxin-mediated compromise of the hepatic microvasculature, causing pronounced hepatocellular necrosis. The importance of the liver's role in defense against systemic infections is illustrated by the fact that when compared to patients with normal livers, patients with cirrhosis more commonly have hospitalizations associated with sepsis and an increased likelihood of death from sepsis. 508 Hepatic involvement in sepsis is much more common in neonates than in adults and is usually from gram-negative bacteria such as E. coli. 507 Hepatic involvement most often occurs in critically ill septic patients, and contributions by such factors as hemolysis, disseminated intravascular coagulation, heart failure, ischemic hepatitis, total parenteral nutrition, drug toxicity, renal insufficiency, or biliary obstruction may cloud the picture. Hepatic involvement in sepsis and lobar pneumonia, in contrast, mainly affects men, perhaps exacerbated by alcoholism. 507 Most cases of pneumonia are due to S. pneumoniae, although Klebsiella pneumoniae and other organisms have been described. Hepatic involvement in sepsis occurs within a few days after the onset of bacteremia, with mild hepatomegaly in 50% of patients but without pruritus or abdominal pain. 504-505-507 Manifestations of the underlying infection dominate the presentation. It resolves slowly with treatment of the infection. Peak serum bilirubin levels, mostly direct-acting, are usually between 5 and 10 mg/dl but can be much higher. Serum alkaline phosphatase is elevated in almost 50% of patients. It is rarely more than 2 to 3 times normal, although marked elevations can occur. Serum aminotransferases are usually normal but can be slightly elevated. Serum LDH is usually normal, as opposed to hypoxic/ischemic hepatitis, where it is markedly elevated. Serum albumin may be low but probably no lower than in non-jaundiced sepsis. Prothrombin time is normal or correctable with vitamin K. Contributions to jaundice include increased bilirubin load from associated red blood cell transfusion and hemolysis. 504 In addition, hepatocyte dysfunction resulting in reduced bilirubin uptake, intrahepatic conjugation, and canalicular excretion promotes hyperbilirubinemia. Bile ducts and cholangiocytes may be involved. Bile duct injury from sepsis and trauma can lead to progressive sclerosing cholangitis, usually small duct disease. This should be in the differential diagnosis when there is persistent hyperbilirubinemia and elevated serum alkaline phosphatase levels after resolution of the sepsis. 504 Liver histology in sepsis, although usually not obtained, reveals portal inflammation, centrilobular necrosis, lobular inflammation, hepatocellular apoptosis, cholangitis/cholangiolitis, steatosis, both macrovesicular and microvesicular, and cholestasis without damage to bile duct epithelium. 507,509,510 Ductular cholestasis, a sepsis-specific hepatic lesion related to cholangitis lenta, is associated with increased mortality. Fig 37.7. 511 No specific treatment for hepatic involvement in sepsis is indicated. Antibiotics excreted by the liver into bile, e.g., ceftriaxone, if indicated, should be used at reduced doses. Prognosis is unrelated to hepatic involvement or to the height of the hyperbilirubinemia in patients with sepsis, but rather to the underlying process. Chapter 37 Gastrointestinal and Hepatic Manifestations of Systemic Diseases 555-37 Cardiovascular diseases. The association of cardiac and liver disease can occur in several settings. 512 Heart diseases may secondarily cause congestive hepatopathy, ischemic hepatopathy, or even cardiac cirrhosis with ascites. Liver diseases may secondarily affect the heart and lungs and include hepatopulmonary syndrome, portopulmonary hypertension, pericardial effusions and cirrhosis, cirrhotic cardiomyopathy 513 and high-output heart failure caused by intrahepatic arteriovenous fistulae in the non-cirrhotic liver, as in Osler-Weber-Rondeau. Other diseases affecting both the liver and the heart/circulation include sepsis and infiltrative disorders such as hemochromatosis, amyloidosis, and sarcoidosis. Heart disease, heart failure, constrictive pericarditis, cor pulmonale, can also affect the GI tract through intestinal malabsorption or PLGE. Ischemic heart disease is a risk factor for ischemic colitis. 514 Fibromuscular dysplasia, a non-atherosclerotic, non-inflammatory vasculopathy, usually affects the renal and carotid arteries but may affect the mesenteric arteries, causing abdominal angina and acute intestinal ischemia. 515 Symptomatic GI angioectasias may occur in patients with aortic stenosis, Hayes syndrome, and many patients, 30%-40%, after left ventricular assist device placement, see earlier, coagulation disorders. Infiltrative diseases. Amyloidosis. Amyloidosis is a group of infiltrative disorders that result from the extracellular deposit of amyloid fibrils composed of a variety of serum protein precursors, along with the non-fibrillar glycoprotein serum amyloid P and glycosaminoglycans. 516-518 Over 20 different proteins have been identified as causative agents. The letter A is used to designate amyloid fibril protein and is modified by a second letter or letters to indicate the specific fibrillar protein. Thus, with primary amyloidosis, the most common form is called AL, with the L representing the fragment of immunoglobulin light chains found in the majority of patients, whether primary or associated with multiple myeloma. Secondary, AA, amyloidosis is due to deposition of serum amyloid A, SAA, associated with a variety of infectious, inflammatory, or, less commonly, neoplastic disorders. The number of patients with AA amyloidosis has declined in frequency in the last 40 years, partly because of fewer chronic infections, e.g., tuberculosis, better control of chronic inflammatory diseases, e.g., RA, IBD, FMF, and increased recognition of AL amyloidosis. Although overproduction of SAA is necessary for the development of AA amyloidosis, it is not sufficient. SAA is an acute phase reactant that increases with many inflammatory diseases. Dialysis-related amyloidosis, A-beta-2M, is due to deposition of beta-2 microglobulin, a protein found in all nucleated cells that is normally metabolized in the kidney. 519 There are several types of hereditary amyloidosis, the most common caused by a mutant transthyretin, TTR, produced by the liver. The resulting amyloidosis, ATTR, is called familial amyloidotic polyneuropathy, an autosomal dominant disorder mainly affecting nerves and cured by liver transplantation. 520 Senile systemic amyloidosis involves the heart, lung, and GI tract with deposition of wild-type, non-mutated, TTR in subserosal veins. 521 Systemic manifestations include nephrotic syndrome, peripheral neuropathy, restrictive cardiomyopathy with heart failure and cardiac conduction disturbances, purpura, raccoon eyes. Macroglossia, joint involvement, carpal tunnel syndrome, and weight loss. Autonomic dysfunction manifests as orthostatic hypotension, diarrhea, and impotence. In the GI tract, amyloid is often deposited in submucosal vessel walls, narrowing and eventually occluding the lumen and resulting in ischemia, infarction, and/or ulceration of the area served by the vessel. Amyloid deposited between smooth muscle fibers causes pressure atrophy of adjacent fibers resulting in gut dysmotility. Amyloid deposited in the nerves of the GI tract can also cause dysmotility, particularly in ATTR amyloidosis. Mucosal architecture usually remains normal until massive deposits of amyloid destroy it, resulting in malabsorption. Oral, esophageal, and gastric involvement. Macroglossia, found most frequently in AL amyloidosis, is virtually pathognomonic, with the tongue that may be dry, fissured, ulcerated, and indented by teeth. 522-523 It may cause airway obstruction, speech difficulties, oral dysphagia, and malocclusion of teeth. Involvement of the submandibular glands may result in xerostomia. Gingival biopsy is of questionable value. The esophagus was involved in 13% of patients in a radiologic study and 22% in an autopsy series. 516,517 The main symptoms are dysphagia, chest pain, heartburn, and hematemesis. There may be an atonic esophagus, ulcerations, or masses suggestive of carcinoma. Basal lay pressure is normal or low, and the amplitudes of esophageal contractions are decreased. Occasionally secondary achalasia may develop, with rapid onset of symptoms and significant weight loss. Gastric involvement occurs in 12% by autopsy and 8% on biopsy during endoscopy. Only 1% are symptomatic, with early satiety, nausea, abdominal pain, vomiting, or hematemesis. Gastric outlet obstruction may occur. There may be gastroparesis, especially with familial amyloidotic polyneuropathy, which affects the autonomic nervous system. Thickened irregular folds may have hypoechoic thickening of the mucosa and submucosa with loss of sonographic wall layer structure. 524 Loss of rugal folds and decreased motility occur when smooth muscle is replaced by amyloid. The most common endoscopic findings are granular appearance, friability, polyps, erosions/ulcers, and enlarged folds. 525 Many types of duodenal lesions have been described: scalloped edges, duodenitis, ulcers, masses, hypotonia, and dilatation. 516,517 Small and large bowel involvement. The greatest amount of GI amyloid is deposited in the small bowel, Fig. 37.8, presenting as diarrhea, steatorrhea, PLGE, hemorrhage, obstruction, ischemia, and infarction, pneumatoses. Fig. 37.7 Liver. Biopsy specimen obtained from a septic patient with marked hyperbilirubinemia and normal serum alkaline phosphatase levels showing cholangitis lenta. Bile is inspissated in proliferated periportal bile ductules, arrows. The interlobular bile ducts in the portal tract are normal in appearance, without bile stasis or injury. HNE, times 25. 556 Part 4 Topics involving multiple organs: cystoids intestinalis, intussusception, constipation, pseudo-obstruction, mesenteric infiltration, and perforation, sometimes due to diverticula. 525,526 Many types of duodenal lesions have been described: scalloped edges, duodenitis, ulcers, masses, hypotonia, and dilation. 516,517 Thickened folds may be due to amyloid in the vasculature causing ischemic enteritis, amyloid in the wall, or edema from hypoalbuminemia. Hypoalbuminemia results from malabsorption, PLGE, and/or nephrotic syndrome. 527-529 Polypoid protrusions and thickening of the valvular connivents can be seen in patients with AL amyloidosis, with diffuse deposition of amyloid associated with mechanical obstruction and chronic intestinal pseudo-obstruction. 516,517 In contrast, AA amyloidosis is associated with a fine granular appearance, with deposits in the mucosa associated with diarrhea, malabsorption, and occult blood in the stool. A-beta-2M amyloidosis is associated with delayed intestinal transit and bowel dilatation due to amyloid deposition in the muscularis propria. Amyloid in the large intestine may be less readily discernible than in the small bowel, with luminal narrowing or dilation, loss of haustrations, thickened folds, nodularity, polypoid lesions, and ulcerations. It may mimic IBD, malignancy 530, or ischemic colitis. Acute pseudo-obstruction, found particularly in AA amyloidosis with deposits in the myenteric plexus, may be reversible. Patients with AL amyloidosis and obstructive symptoms due to amyloid infiltrating smooth muscle have a poor prognosis. 516 Diarrhea may be due to rapid transit from autonomic dysfunction. 531 Delayed transit resulting in SBBO, bile acid malabsorption from fast transit or SBBO, or pancreatic insufficiency from ischemia of acinar tissue by amyloid deposition in vessels. Although often resistant to conventional therapies, somatostatin analogues and enterostomy have provided relief of diarrhea in case studies. 516,517,528 Steatorrhea is common in familial amyloidotic polyneuropathy but not AL amyloidosis. Weight loss, often severe, and malnutrition adversely influence survival. Hemorrhage may be due to direct vascular and tissue infiltration, with increased friability or ischemia, specific amyloid lesions, or fragility of blood vessels and impaired vasoconstriction. 532 Acquired coagulation abnormalities such as factor X deficiency are found, particularly in AL amyloidosis. A prolonged prothrombin time may be due to liver dysfunction, malabsorption, decreased vitamin K intake, or reduced factor X. Amyloidosis occurs clinically in 0.9% of patients with Crohn's disease and in 0.07% of patients with ulcerative colitis, although the prevalence is higher in autopsy data. It is associated with suppurative complications, found particularly in Crohn's disease, usually taking about 15 years to develop. 533 Hepatic involvement. Hepatic amyloidosis has no clinical significance in the majority of patients, except in familial amyloidotic polyneuropathy, where the liver is the main organ involved. Symptoms, when present, include weight loss, fatigue, abdominal discomfort, and anorexia. 534 In patients with primary amyloidosis and biopsy-proved liver involvement, hepatomegaly, sometimes massive, and an elevated serum alkaline phosphatase level are the most frequent findings, although the degree of liver chemistry test abnormality does not correlate with the extent of hepatic amyloid deposition. Ascites is more often due to cardiac failure than to liver disease. Stigmata of chronic liver disease, e.g., portal hypertension, jaundice, are uncommon. Splenomegaly is usually associated with hepatomegaly. Occasionally the spleen or liver may rupture. 535 Amyloid may be a cause of increased liver stiffness. 536 Amyloid deposits can be sinusoidal or vascular. They usually begin periportally in the space of Ds, followed by hepatocyte atrophy due to compression by amyloid fibrils. 516 When amyloid blocks the sinusoids, portal hypertension develops. Sometimes amyloid infiltrates the portal blood vessel walls. In those with suspected hepatic amyloidosis, a subcutaneous fat aspirate or a bone marrow biopsy are usually positive, 80% and 82%, respectively, providing a diagnostic alternative to liver biopsy, which may carry an increased bleeding risk from hepatic amyloid infiltration. 534 Hyperbilirubinemia is associated with a poor prognosis. Diagnosis in AL amyloidosis, serum and urine should be tested for monoclonal light chains, which are found in 89% of patients by immunoelectrophoresis with immunofixation. The latter is used so as not to miss a small monoclonal, spike. A bone marrow aspirate and biopsy should be performed to quantify the number and monoclonality of plasma cells. Common biopsy sites include the kidneys, liver, subcutaneous fat, bone marrow, and the GI tract. Gastroduodenal biopsies correlate well with renal biopsies and are much less risky. 537 The positivity of GI tract biopsies increases if submucosal vessels are sampled. Amyloid in oral biopsies is demonstrated in 88% in the subepithelial connective tissue from diseased areas. 538 Whereas blind biopsies of the mouth are of little diagnostic use. The risk of bleeding with percutaneous liver biopsies is controversial, with some investigators reporting an increased risk of hemorrhage. 516 Bleeding may be due to coagulopathies from reduced hepatic synthesis or malabsorption of vitamin K-dependent clotting factors, factor X deficiency, and amyloid infiltration of vessels, which once lacerated may not vasoconstrict normally. According to one study, those with bleeding from a procedure had normal clotting studies but a history of bleeding problems. 516 Amyloid stains pink with H&E, Fig 37.9a. With Congo red staining, it has a red appearance in normal light and an apple green birefringence in polarized light, see Fig 37.9b. Pretreatment with potassium permanganate does not affect staining affinity for Congo red in AL amyloid, but often eliminates this affinity in AA amyloid. Immunohistochemistry performed on biopsy samples is important because it impacts treatment. 539,540 Fig 37.8 Film from a small bowel series in a patient with amyloidosis. Small bowel shows symmetric, sharply demarcated thickening of the valvuli connivents throughout the small intestine. Courtesy Marshak R.H., M.D., New York. Chapter 37 Gastrointestinal and Hepatic Manifestations of Systemic Diseases 557-37 Treatment and Prognosis. AL amyloidosis is treated with myeloma-type chemotherapy or high-dose chemotherapy plus hematopoietic autologous stem cell transplantation to eliminate the B or plasma cell clones. 541,542 Morbidity is high, but the median survival is greatly increased, and amyloid deposition may regress. For AA amyloidosis, control of the underlying inflammatory disorder leads to reduction of SAA and disease progression. Anti-TNF agents result in clinical improvement in patients with AA amyloidosis associated with Crohn's disease. 543 Colchicine decreases symptoms and prevents amyloid deposition in patients with familial amyloidotic polyneuropathy and FMF and appears to benefit patients who have already developed amyloidosis. 516 For dialysis-related amyloidosis, renal transplantation results in a fall in serum beta-2M levels and a slower decrease in amyloid deposition. For hereditary amyloidosis, where the precursor protein, mutant TTR, is produced solely by the liver, such as in familial amyloidotic polyneuropathy, liver transplantation is curative, with improvement in GI symptoms and nutritional status in a substantial proportion of patients. 544 The explanted liver is normal, other than its production of amyloidogenic proteins, and is not a site of amyloid deposition. Octreotide has been used to treat refractory diarrhea in patients with AA amyloidosis. 516 Dysmotility may respond to prokinetic agents, according to anecdotal reports. Surgery is difficult and carries a number of risks: bleeding, impaired wound healing, anastomotic dehiscence, perhaps related to amyloid deposits in the resection margins, malnutrition, and multi-organ failure, particularly heart and renal failure. Patients with AL hepatic amyloidosis have a median survival of less than 1 year, particularly those with heart failure and/or hyperbilirubinemia. The majority of deaths are related to cardiac or renal complications or, in the case of multiple myeloma, to progression of the underlying malignancy. 534 Morbidity and mortality are rarely determined by extent of hepatic involvement. Granulomatous liver disease. Granulomas, an organized collection of immune cells that attempt to wall off what the body sees as foreign, are often found in the liver as a primary process or a manifestation of a systemic disease. 545-548 They are found in 2% to 15% of liver biopsies, most often near portal tracts. Many etiologies must be considered, Table 37.2, with 10% to 30% being idiopathic. Probably the most common cause in the developed world is PBC, whereas the most common etiologies in the developing world, and in older studies, are infectious diseases, especially tuberculosis. Although usually asymptomatic, patients with hepatic granulomas may present with hepatomegaly, right upper quadrant pain, fever, and/or weight loss. Granulomas associated with infections that require a macrophage-based pathway for clearance commonly comprise a mixed infiltrate and tend to be casating with central necrosis. Those in immunologically mediated diseases are usually associated with dense lymphocytic infiltrates. Foreign body granulomas from indigestible particulate matter such as starch, silicone, or mineral oil, and lipogranulomas have minimal inflammatory infiltrates. Epithelioid granulomas, as in sarcoidosis, certain infections, toxins, and drugs, contain activated macrophages resembling epithelial cells. Fibrin ring granulomas consist of an epithelioid granuloma with a central lipid vacuole surrounded by a fibrin ring, classically described in association with Q fever but seen in a variety of other diseases. 548 Granulomatous inflammation is characterized by poorly formed granulomas with indistinct edges, often associated with hepatocellular and/or duct damage. The pathologist reading the liver biopsy should attempt to determine the location of the granulomas, the presence/absence of necrosis, the type of accompanying infiltrate, any organisms or foreign material in the granuloma, and associated findings. Rare complications are usually due to compression of adjacent structures by the granulomas, resulting in portal hypertension, intrahepatic cholestasis, biliary stricture, hepatic vein thrombosis, and cirrhosis. 546 Workup, where appropriate, includes a chest X-ray, cultures for bacteria, including Brucella species, mycobacteria, and fungi, serum AMA, serologies for Q fever, brucellosis, syphilis, HBV, and HCV, PCR for infectious pathogens, and TB testing. Sarcoidosis. Sarcoidosis is a multi-system granulomatous disorder of unknown cause. 549. This disease generally occurs in those ages 20 to 40, with an increased incidence and mortality in African Americans compared to Caucasians. Patients may have constitutional symptoms, lung disease, adenopathy, granulomatous uveitis, proximal myopathy, lupus pernio, cranial nerve palsies, erythema nodosum, hypercalcemia, and granulomas in many organs. Increased levels of angiotensin-converting enzyme, produced by the epithelioid cells in the granulomas, are a weak diagnostic test. The Kvamme-Siltzbach test is the intradermal injection of sarcoid tissue extract, followed 4 weeks later by a biopsy of the papule that develops in the area. Availability and ethical constraints limit its use. AB Fig 37.9a, histopathology specimen showing submucosal vessels with amorphous eosinophilic material, amyloid, within the tunica media of a mesenteric artery. B. Submucosal vessel showing apple green birefringence by Congo red stain. From Ebert E.C., NAG-RM gastrointestinal manifestations of amyloidosis. AMJ Gastroenterol 2008. 103:776-87, with permission from Nature Publishing Group. 558 Part 4 Topics involving multiple organs. Gastrointestinal involvement. GI involvement in sarcoidosis is rare. 550-552 Mucosal granulomas may be an incidental finding, and other diagnoses, such as tuberculosis or Crohn's disease, must be thoroughly ruled out, particularly before embarking on immunosuppressive therapy. The esophagus is rarely involved, resulting in dysphagia or reflux. Mucosal involvement can cause aphthous lesions, plaques, or nodules. 553-556 Muscular or neuropathic involvement causes a dysmotility in the cricopharynx or produces an achalasia-like picture responding to glucocorticoids. Mechanical obstruction of the esophagus may occur from compression by hilar or mediastinal lymph nodes, and infiltrative esophagogastric junction outflow obstruction may be seen on high-resolution esophageal manometry. The most common GI site involved is the stomach end, although usually asymptomatic. Such involvement may cause pain, early satiety, nausea, and vomiting. See Chapter 52. A variety of lesions, particularly affecting the antrum, have been reported: ulcers, thickened folds, a linitis plastica type picture, and extrinsic compression by retroperitoneal adenopathy. 554-557 Whether the granulomas are incidental findings or causing symptoms is often unclear. Isolated granulomas of the stomach are more commonly due to Crohn's disease than to sarcoidosis. Duodenal involvement from sarcoidosis is rare. 558 There may be an association between celiac disease and sarcoidosis, perhaps because both disorders are linked to HLA-DQ2 and HLA-DR3, result from defective antigen processing, and involve an increased expression of class II HLA molecules. 559 Bowel involvement is rare in sarcoidosis, the main differential diagnosis being Crohn's disease. Distinguishing features suggesting sarcoidosis are the rare Schaumann bodies, concentrically laminated intracellular inclusion bodies, granulomas outside the GI table. 37.2 Some causes of hepatic granulomas * infections, neoplasms, medications, miscellaneous causes, bacteria, Hodgkin lymphoma, allopurinol, autoimmune hepatitis, Bartonella Hensley, cat scratch disease, non-Hodgkin lymphoma, carbamazepine, bacille, Calmette-Guerin, Borrelia species, Lyme disease, cephalexin, biliary obstruction, Brucella species, renal cell carcinoma, chloropropamide, common variable, immunodeficiency, Francisella tularensis, tularemia, chlorpromazine, Listeria monocytogenes, listeriosis, dapsone, Crohn's disease, Mycobacterium avium, intracellulare diazepam, foreign body, talc, starch, Mycobacterium leprae, leprosy, diclofenac green juice, Mycobacterium tuberculosis, dicloxacillin, idiopathic nocardia species, diltiazem, metal toxicity, beryllium, copper, Salmonella typhi, typhoid fever, Adanercept PBC. Treponema pallidum, syphilis, glyburide PSC trophiema Whipplei, Whipple disease, gold sarcoidosis Yersinia enterocolytica hydralazine silicone injections Rickettsia species infliximab SLE coxella burnetii, Q fever, interferon granulomatosis with polyangiitis viruses isoniazid CMV mesalamine EBV methyldopa HCV nitrofurantoin in fungal diseases oral contraceptives actinomycosis oxacillin coccidioides immitis, coccidioidomycosis, penicillin cryptococcosis neoformans, cryptococcosis. Phenytoin histoplasma capsulatum, histoplasmosis, procainamide parasitic diseases procarbazine fasciella hepatica, fascioliasis, quinidine leishmaniasis quinine schistosomiasis rosiglitazone toxocara canis and cauda, visceral larva migrans, saridon, excedrin, toxoplasma gondii, toxoplasmosis, sulfonamides *. Also see chapters 35, 84, 88, and 91. Chapter 37 Gastrointestinal and Hepatic Manifestations of Systemic Diseases 559 37 Tract, and a dramatic response to glucocorticoids. Fistulas, architectural distortion, and acute inflammation are uncommon. Patients may present with intestinal obstruction, from masses, strictures, or external compression from lymphadenopathy, pain, chronic diarrhea, PLGE 560 or bleeding from ulcers or colitis. 558,561 Pancreatic sarcoidosis is quite rare, presenting as an enlarged pancreas, biliary obstruction, abdominal pain, acute pancreatitis, or pancreatic insufficiency. 562 Serum amylase and rarely lipase may be mildly elevated. 563 Acute cholecystitis may occur secondary to extrinsic compression of the cystic duct by lymph nodes or by granulomatous inflammation of the gallbladder. 564 Obstructive jaundice may develop from granulomatous involvement of the bile ducts or surrounding lymph nodes. Granulomas in the gallbladder wall may be discovered after cholecystectomy for cholecystitis. Unlike lymphoma, abdominal adenopathy in sarcoidosis is characterized by lymph nodes that are generally less than 2 cm in diameter, discrete, rather than confluent, and spare the retrocrural area. 565 Sarcoidosis must be differentiated from sarcoid-like reactions found in lymph nodes of patients with cancer. EUS with fine needle aspiration can identify granulomas in most patients. 566 Ascites is rare and usually due to right heart failure or portal hypertension. However, peritoneal stutting with small nodules may cause a lymphocytic ascites. 567 CT may show infiltration of peritoneal ligaments and mesenteries. 568 Peritoneal biopsy is needed to confirm the diagnosis and rule out tuberculosis, fungal infections, and malignancies. Ascites usually resolves spontaneously or with a short course of glucocorticoids. Sarcoidosis may uncommonly be triggered by interferon therapy, generally within the first 6 months, usually involving the lungs and skin. Most patients improve after stopping interferon, although a few require glucocorticoids. 569,570 Occasionally, treatment-naive patients with HCV may develop sarcoidosis. Sarcoidosis has been described in patients receiving natalizumab for Crohn's disease. It is unclear if this may occur with vitalizumab. 571 Hepatic and splenic involvement. Hepatic involvement is usually asymptomatic, with normal liver chemistry tests. 550,552, 572, 573 The most common symptom is abdominal pain. Jaundice is rare and may be due to intrahepatic cholestasis, hemolysis, hepatocellular dysfunction, or obstruction of the extrahepatic bile ducts by enlarged lymph nodes. Hepatomegaly is found clinically in about 21% of patients and in more than half of patients on abdominal CT scans. About 20% to 40% have abnormal liver chemistry tests, usually with high serum alkaline phosphatase levels and less prominent elevations in serum aminotransferases. 550,574 Hyperglobulinemia is quite common. 1/4 of patients in a report had liver without lung involvement. 575 Finding granulomas on liver biopsy can aid in the diagnosis of sarcoidosis. Granulomas are mainly in the portal and periportal zones with a cluster of large epithelioid cells, often with multinucleated giant cells, Fig 37.10a. There is a high turnover rate of granulomas, and large confluent granulomas lead to hyalinized scar formation. Only rarely do hepatic granulomas contain Schaumann bodies or asteroid bodies, stellate-shaped inclusion bodies. Although frank caseation is not seen, central necrosis of granulomas may occur. A wide array of histologic features may occur, categorized as cholestatic, necroinflammatory, and vascular. Cholestasis may be due to sarcoidosis of extrahepatic bile ducts, bile duct compression by enlarged perihilar lymph nodes, involvement of the pancreas, or associated PBC and PSC. 572 patients with intrahepatic cholestasis may have progressive destruction of bile ducts by granulomas, leading to depletion of interlobular bile ducts, periportal fibrosis, and biliary cirrhosis similar to PBC. 550. 572 others may have a pattern of periductular fibrosis reminiscent of PSC. Unlike PBC and PSC, patients with sarcoidosis usually have normal serum IgM levels, negative AMA, and negative ANCA. In addition, they may have rapid improvement with glucocorticoids not seen with PBC or PSC. Both PBC and PSC may be associated with hepatic granulomas, see Table 37.2, but the typical bile duct findings of these diseases are less conspicuous or absent in sarcoidosis. Rarely, PBC or PSC coexists with sarcoidosis. Some patients have acute cholangitis suggestive of mechanical obstruction without true ductal obstruction. Necroinflammatory disease or hepatitis-like changes may be found, as well as vascular changes such as nodular regenerative hyperplasia or sinusoidal dilatation, mainly affecting the pericentral zone. Rarely, hepatic vein thrombosis results from veins narrowed by extrinsic compression or granulomas in the vessel walls. Fibrosis may be limited to the portal-periportal area or progress to portal-portal bridging fibrosis or even cirrhosis. A small proportion of patients develop portal hypertension due to a pre-sinusoidal block or pre- and post-sinusoidal resistance from hepatic ischemia secondary to granulomatous phlebitis of portal and hepatic veins. 573 Because cirrhosis is rare and liver function is usually preserved, encephalopathy and liver failure are unusual. In a retrospective study of 350 patients with AB Fig 37.10 sarcoidosis, A. Histopathology showing non-caseating granuloma within a lymph node. There are aggregates of epithelioid histiocytes and Langhans-type giant cells surrounded by lymphocytes, with no central necrosis. B. CT of the abdomen shows multiple hypodense lesions in the liver and spleen, proved to be granulomas in a patient with sarcoidosis. From Ebert E.C., Kierson M., Hags-Peel K.D. Gastrointestinal and hepatic manifestations of sarcoidosis. AMJ Gastroenterol 2008, 10330-18492, with permission from Nature Publishing Group. 560 Part 4 Topics involving multiple organs. Sarcoidosis, hepatic involvement occurred in 19.6%. About 16 underwent liver biopsy and non-caseating granulomas were found in 88% of them. About 4 patients, 20%, developed cirrhosis over a mean follow-up of 10 years after diagnosis of hepatic sarcoid. 576 Sarcoid granulomas are typically small and not detectable by radiographic studies. However, if they cluster to form large aggregates, perhaps surrounded by fibrosis and/or inflammation, they may appear as innumerable small nodules on imaging studies, see Fig 37.10b. On CT, they are low attenuating and non-enhancing after contrast injection. 572 On T1 and T2 weighted MRI, they present as hypodense lesions without enhancement after gadolinium injection. Lesions take up fluodeoxyglucose on positron emission tomography and can be used to monitor disease progression or remission. Sarcoidosis has a high rate of spontaneous remission, and because there are no large controlled trials evaluating treatment, it is unclear if and when to treat hepatic sarcoidosis. 577 Liver chemistry tests, but not necessarily liver histology, may improve on glucocorticoids, and progression to cirrhosis may still occur. Only case reports support the use of other agents, such as ursodeoxycholic acid, chlorambucil, azathioprine, or methotrexate. Disease recurrence after liver transplantation can be a rare cause of graft loss or patient death. 578 Splenic involvement in sarcoidosis is usually asymptomatic but may present with left upper quadrant abdominal pain, constitutional symptoms, hypersplenism, and rarely rupture. Splenic nodules tend to be small, discrete, and multiple, but coalesce with increasing size. See Fig 37.10b. 579 up to 50% have associated hepatic lesions. The differential diagnosis includes infections, tuberculosis and histoplasmosis, benign lesions such as hamartomas and hemangiomas, and malignant lesions such as lymphoma. MRI is useful in characterizing these lesions. Glucocorticoids may be helpful for severe splenomegaly. Others eosinophilic infiltration of the GI mucosa occurs in eosinophilic gastroenteritis. See Chapter 30, the hypereosinophilic syndrome, eosinophilic granulomatosis with polyangiitis, PAN, and gold toxicity. Langerhans cell granulomatosis, histiocytosis X, eosinophilic granuloma, also may infiltrate the GI tract. Small vessel hyalinosis is a rare familial syndrome consisting of diarrhea, rectal bleeding, malabsorption, and PLGE, combined with poikiloderma, hair graying, and cerebrovascular calcifications. 580 Pathologically, basement membrane-like deposits can be seen in the subepithelial space of intestinal capillaries, arterioles, and small veins.